चेक। हाल है। हाल है। चेक। हाल है। चेक। हाल है। चेक चेक चेक। हाल है। ठीक है। चेक चेक चेक। हाल है। चेक। हाल है। हाल है। हाल है। चेक। आज कैप्चर किया था इसको तुमने? कैप्चर आज किया था? चेक। हाल है। महेश।
Hello, good morning. Hello, good morning, good morning, good morning. Hello, check 1 2 3 4 5 6. Hello, sound test, sound test, sound test. Check 1 2 3 4 5 6. Hello, थोड़ा और लेवल दो इसको. थोड़ा ये बढ़ाना, लेवल बढ़ाना. महेश चेक करना. ओके है. हेलो चेक 1 2 3 4 5 6. हेलो 1 2 3 4. हेलो नहीं, थोड़ा और लेवल दो. पूरा बढ़ा देना उसको. पूरा फुल कर उससे. पूरा फुल कर दो. पूरा फुल कर दो. नहीं नहीं, वहाँ से नहीं, तू अपना बढ़ा नहीं, इसे फुल करना. तो इसे फुल कर. हेलो 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 हेलो. और फुल कर इसे पूरा. नहीं नहीं, वहाँ से कुछ नहीं करते, वहाँ से सिलेक्ट करते हैं ओनली. हेलो 1 2. अपना किस पे दिया हुआ है वहाँ से? ठीक है. लेवल मतलब महेश से पूछो, आ रहा है ना? ऑडियो आ रही है ना? कोई हमिंग तो नहीं है? पूछो. हेलो. तो ये चालू करना. ठीक है ना? लेवल कम है, अभी बढ़वा देंगे.
हेलो हेलो।
चेक चेक. हेलो देखो वहाँ पे अब. चेक चेक चेक. हेलो हेलो हेलो. चेक चेक. सर. चेक चेक. हेलो हेलो. शर्मा जी से पूछना भाई.
Hello.
नेम प्लेट किसके पास है? नेम प्लेट नेम प्लेट किसके पास है? प्रांजल को भेजो जल्दी। ठीक ठीक, उसको फ़ोन करना जल्दी आने के लिए MR19 में। जल्दी जल्दी जल्दी, हाँ। Yes. हेलो। Yes, नेम प्लेट। Yes, I'm हेलो हेलो।
check, hello.
Good morning. It's a difficult to fill a room on a 9 a.m. on a Sunday morning for sure, but whoever is here will request you to please take your seats and we'll get this discussion going. So today's session we are going to talk a bit about digital health. And essentially how we can build ecosystems around digital health. I have a great panel here with me. I'd like to start by inviting J. Satyanarayana sir to please join us. He's been the chief advisor for C4IR India from the World Economic Forum. He, of course, many of you know, he headed the committee for India's National Digital Health Blueprint, and he's also supported several countries in Southeast Asia on their digital health strategies. He's been an advisor to the National Health Authority and also the chairman of UIDI. Welcome, sir. Really glad to have you here. I'd like to invite Dr. Dinesh Arora, who's the principal health specialist at ADB. He was also part of NHA, instrumental in setting up NHA, and he has helped really build National Health Authority into a very strong digital health organization for India. I would love to get his insights from there. Could we have Dr. Smisha Agarwal join us? I think maybe she stepped out. Right there. Oh, I see her. Sorry, I thought I was looking around for you and then I see you. Dr. Smisha is the director at the Center for Global Digital Health Innovation and also an assistant professor at Johns Hopkins Bloomberg School of Public Health. She's been leading Digital Health Exemplars, a project that is studying how exemplar countries have used digital technologies to improve both primary care and health outcomes. So it will be great to get your insights today, Smisha, Dr. Smisha. I'd like to invite Dr. Angela Chaudhary, who's the Chief Executive Officer at Swasti. It's a global not-for-profit, and she's been working with a lot of marginalized communities to both improve health, counseling, social protection, and with use of digital technologies. And so I hope that will provide great insights into this panel. We have Mr. Pradeep Kakatil, who's the CEO of Health Innovation Exchange. So very interesting exchange where they've been connecting digital health startups with both funders as well as policymakers. And we have Mr. Manish Deshmukh, who's the global head of Merrill Life Sciences. Merrill is a medtech company. They make everything from cardiac stents to diagnostic equipments in primary care. And lastly, we have Mr. Madhusudan Yadav, who's the health specialist from ADB, and he's been working in primary healthcare across many places. So very good set of experience here on our stage to get us started. I think when we think about digital health, I think when we look at the world today, it is pretty much impossible for us to imagine any initiative and improving healthcare delivery that does not somehow involve technology. I think all of us lived through the COVID pandemic, and if you go back, while it's almost getting forgotten in our memories on how life was at the time, but if we just go back a bit, if we did not have and if we did not effectively use technology, we could not tell where the COVID cases were. Many countries, including India, used technology to try to do things like contact tracing. We had systems to tell us, where was the nearest vaccine that we could get when we wanted it and get a slot for it. And we still have systems that shows that, we have all got our COVID vaccination records. And it was really useful when we started first. Traveling kind of started opening up. So clearly, tech is going to be pretty pervasive in whatever we are doing in healthcare. And now we are also entering this new world with AI, where AI is bringing a whole range of innovations again into healthcare, and things are changing very rapidly, with smartphones being available down to the health, all community health workers and so on. What we can do with a combination of AI, these smartphones, as well as a whole bunch of wearables that are coming in, the future indeed looks really bright. But that said, there are still lots of challenges. As we generate lots and lots of health data, it means we have to be really careful about data privacy. Is it really, health is a sensitive subject in many aspects. So health information is sensitive information, and so are we doing enough about that? Data is also, there's been lots of initiatives, and we'll talk a bit today in the panel about interoperability. Is it really working? Is it really actually bringing the data together and helping us provide better outcomes? Where are we on that? There's lots of headwinds there, lots of challenges to be solved. And while digital health really works, I think, very well for many of us in the room who carry around smartphones, is it really equitable and inclusive for everyone? Does the illiterate person who doesn't even carry a phone, where does digital health feature in their lives? So I think this is something that I think we all want to look at as we discuss the challenges around digital health. The good news is most countries now recognize that they have to have a strategy and a policy around digital health. So, the national health policies of most countries are also now being aligned, and they're building digital health strategies or policies and trying to build a digital health ecosystem. So we'll try to hear from the panelists what their experiences have been, what's the role of government in terms of trying to foster these positive health ecosystems. And that's really what the focus of the panel here is going to be today. So let me start quickly with Dr. Dinesh Arora. Dr. Dinesh, you have been one of the key architects on the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, a scheme that covered over 500 million people when it launched. We are all aware that the launch of such a scheme was almost challenging without the use of tech, and tech played a very key role in getting it off the ground. So can you share some reflections on what was your experience with ABPMJY implementation, and also what do you think it takes to develop robust digital health ecosystems for healthcare? And what should be the key considerations when countries are trying to build digital health ecosystems, especially on technology adoption?
Well, thanks, Kiran, and I think this was a great effort in the NHA. I can see Dr. Satya here, you yourself, and Nishant sitting in the first row. Now, I'm just worried that sometimes in a panel, audience is more prized than the panel itself. Sunday morning, 9 o'clock, I really give a lot of, we should all thank those who are sitting here. So should I call Nishant to sit in Dodo's place, or should be sitting there, because panel audience is so important for us? So, but feel free to intervene, Nishant, wherever you can. But let's give a big hand to all those who are present here today at 9 a.m. on a Sunday morning. And Kiran, let me go one step back. You were saying there can't be done anything without technology. It's totally right. But if you see there is some kind of a, digital maturity index in different industries, I think health will be a laggard there. Imagine digital payments or booking an airline, booking a tourism package and all. You do online sitting today, but do we book appointments like this? Do we have our electronic medical records like this at the help of the hair? What we want to do, we don't want to do. Can booking.com help me in that? I don't think so. So I think the digital maturity index is pretty poor for health, and it's not difficult to fathom why it's that though. The health is very fragmented, complex, federated, different tiers of healthcare. But is this a reason that people like me who are doctors, who consider themselves qualified, are perhaps the biggest resistance? I just leave that question for later, Mark. But I'm not a digital health expert, but I do a public policy for sure. And for me, any technological adoption is a strategic one. It's less of a technical, more of a strategic one. So if you place them in different pillars of how a technology gets embedded in any of the ongoing schemes, programs, I think it starts with an innovation. Then you should have an adoption matrix, which should be very simplified. Then perhaps demand creation, literacy, education about this. And then finally, safety and regulation start coming. The problem in most places is that first we start with regulation. Sorry, sir, the IT ministry will first say, let's regulate first, come with the guidelines, then we'll have an innovation. Innovation will precede regulation, not the other way around. And most important thing is adoption, where adoption needs to have incentivization. Now, I wanted to share my experience when we were asked to launch PMJY. Nishant, on 23rd September, we were asked, the scheme was announced on 2nd February, and we were said the scheme will be launched all over India for 500 million on 23rd of September. In fact, the PM had asked for 15th August when we said no, we want at least 1 month of testing pilot because the IT was the most important component. So how did we start that program? We said, let's identify the right people. So the two people on my right were the right people. Kiran and Satya sir were there. And my job was to get the scout as a deputy CEO to get the best team established, enable them, and then support them. So we got the best people on this side, and they were with us. And I'm hugely thankful to Mr. Amitabh Kant for this, because I met Kiran during his meetings with Nandan, and also Mr. Indu Bhushan, who actually was very pioneering and futuristic on these technologies. Nishant was advising us on the core health side, on the packaging and all. We came up with a problem. The problem is we wanted a software which would be seamless, paperless, right from the initial starting when the patient comes to the hospital and when he gets discharged, he or she gets discharged. A portal which can also do some kind of fraud detection, because this was an insurance sector where we were opening it to the private sector and many people were very apprehensive. And of course, a seamless experience even for the providers with the real-time data. How do you get the claims done in real time? 3 things were our problem statements given to the team that this is what we want to do. So we started from a problem, not from a product. That this is a product, let's do it. Second issue came product. Now, do you reinvent a product or you buy off the shelf? There are lots of companies you tell I want an insurance package, they will come forward to you and say, hey, we have a project ready, we did this in Turkey, we did this in US, can you buy this? So we went across and we saw that there were many states who were doing good. Should we take that model and work on this? And that is where we zeroed upon. I think we took the TCS Arogeshri one, or Arogeshri one, which was being done in Andhra, Telangana, and no qualms in saying that whichever state had done better, we picked up from there. Now, third question, and which was a bold bet for us, should it be a federated one or should it be a centralized one? I mean, the software, we take the charge, everybody starts using it. So, and the other way around is that every state is using it, we just take the APIs and pull in the data. Now, this was a considered decision, and perhaps we went against the ministry here and said, nay, we will go for centralized core. So more of a hybrid, centralized core with our own standards, our own data sets, what we want to get from them, but allow them flexibility in implementation, in customization. They want to add more people, more packages, they want to deal with them, that was allowed. So that came as our core risk, but I think that is perhaps a strength of PMJY today. And when the data was coming, we could see from eyes what policy decisions were required. But going forward, so Fuji had a problem. We got the software, we got the design of the software, and then the next step was infrastructure. We need iris readers, or we need the handheld devices, we need computers and all. That was made arranged. Connectivity, and then perhaps also the mobile version, the offline version, they all evolved. Different languages version evolved as we move forward. And finally, the most important, scaling. You can have a software, but unless people are skilled, people are used to work, how simplified you can make it, how easy adoption can be done. These were some of the things which we actually put into the place and got them done. Of course, the next level did come for privacy, for confidentiality, and of course, grievance mechanisms also got evolved. So for me, technological ecosystem building is more of a strategy rather than just being a question of a technical one. So when we need to put our heads together how we get this done and make it simpler for people to adopt. And today I have no qualms in saying that perhaps this was one of the best 1 year we had. We had lots of failures, Kiran. So we said to Prime Minister that we will have one district tested in every country before we launch from 23rd September. And you won't believe it, the first day didn't work most of the places. And then slowly and slowly it picked up, and then we had a war room, teams there, applications raised, lots of good consulting people were with us. And I think this is how we pulled it, and today, more or less, it's stabilized. One caveat, when we were there, we were definitely using the data which was coming for policy decision. I'm not sure whether it's being used now or not, because it's very important. You can set up a technical digital ecosystem. Unless you are making policy decisions from it, again, it's It's just lying there as a data and not being used. I'll stop here, but for me, this was one of the good steps where all policy decisions were figured on how we get them adopted to the field, rather than just coming up with a perfectionist solution, perhaps which is not incentivized enough for people to adopt it. I think I'll stop here. Thank you.
Great. Thanks, Dinesh.
To what Dinesh said was that original target date was 2nd of October. It was advanced to, I think, 23rd. So we are 10 days short of the original target. We had to do it, September.
Testing.
Just one thing more, I just missed the point, was that, when you build a digital ecosystem, let's not government try to do it alone. So get the best partners, get the sandbox, get the private sector along with it. This is the crux. Most people have done those things in the private sector. We just need to customize it, give our problem statement and use it, rather than having that distrust that government has to do everything ourselves. Thank you.
Great. Thanks so much, Dinesh. So I think I'll, take forward, what you just left at the end with, which is the importance of, partnerships and building ecosystems. So Satyanarayana sir, you have been the architect behind, the National Digital Health Blueprint, which is now running as the Ayushman Bharat Digital Mission. And in the Ayushman Bharat Digital Mission, one of the key things is about the government plays a role. It has certain building blocks, but it's really about bringing the ecosystem together, and it's really about partnering with the ecosystem to kind of, get the digital health ecosystem really go forward. So what are your views on what are the best models to drive this partnerships, the governance around that, as well as, your view on, what it takes to really build healthy ecosystems? That's one. Second, as part of the World Economic Forum, AI is really coming into a big way into our lives, and I think as I look at the next decade, it is likely that it will touch us in ways that we still don't fully understand. And one of the things that bothers many of us who work in this space is about the concept of responsible AI, right? And so at the World Economic Forum, you folks have been actually looking at this problem of how to make sure that happens. So tell us, also share us some experiences around what that is likely to look like.
Thank you, Kiran. I think with that intro to PMJF by Dinesh, and then the intro to ABDM, what does it take? I mean, there are two parts to the question. How do you build an ecosystem using partnerships and governance? And the second one is about responsible AI. Let me deal with each of them. I have a fundamental discomfort with the title to this session. Data to diagnosis. Where is the doctor? So I would say those who are doctors, I'm not a doctor myself, but I would have said data to doctor to diagnosis. 3 Ds instead of 2 Ds. I think that it's not just for, in a lighter way, in a serious way. In the countries wherever we have seen, one of the, I would not say challenges, but enablers in a positive way is the doctor. You have the best of software, everything done, very good portals and AI, BA and all that. End of the day, if the ecosystem of doctors, the physicians and other health professionals who are there, both in public and private sector, decide one way, it goes that way. So my first response would be, whatever is the ecosystem that we are talking about, one of the very key figures there is the doctor. So the route to successful adoption is the doctor's mind, I would say, mindset. Having said that, let me just see how you can do that. First of all, there should be a method for building the capacities among doctors and the change management. There are a lot of misconceptions and apprehensions, etc. Dispel those things first and building capacities. In fact, Kiran and I held a 3-day workshop in one of the Southeast Asian countries exclusively for the doctors and to clear some of the fundamental doubts and apprehensions. The second is, how do you make digital health not an extra item of work for the doctor, which is really tedious and weighing down on them, on their time especially. If instead of facing the patient, they face the PC, what is it that we are doing? So, the digital health should be in such a manner that it makes life much more easier for the physician than otherwise. The work to be done on the PC should be, for instance, today we have AI which understands, and when we were designing NDBH, ABDM, etc., we never had this much of confidence or visibility into AI. Today it is really mainstream. Today, if I were to kind of rewrite the NDHP, National Digital Health Blueprint, I would rename it as National Intelligent Health Blueprint. Instead of digital health, we should be talking of intelligent health seriously. So that the whole ecosystem, right from the doctor to the pharmacist to the patient to the nurse to the frontline worker, it's mainstreamed, and then it's not a burden at all, but it's a pleasure to kind of work in a digital environment. So AI enabled, where the doctor is simply talking and then EMR gets generated automatically without any effort, should be the goal. Then it makes it very implementable. And the other thing is that it should the standards is one more barrier I observed, that are so heavy in their footprint, and the understanding of all the terminology is extremely difficult, whether it is fire or whether it is snowbed city or loink, etc. How do you, and most often as per WHO studies, also 80% of the contact of the patient should be in the primary care. Most of things that can be taken care of at that level get escalated straight away to tertiary care, which is not the right thing. Assuming that 80% is at the primary level, then why do you need an MRI related terminology at the primary center where you don't even have that equipment? So we need the standards, etc., also to be, it's a conscious decision, so it's an effort that is required to simplify. It's very difficult to simplify things, easy to complicate things. So how do we simplify the standards that suit exclusively the primary care is one more area for adoption, is what I would say here. Now there are two more things in adoption, which is we need to balance the demand side and the supply side. Why is UPI such a great success here? Because there is a huge unexpressed demand for this kind of a trivialization of payments. So very easy, intuitive kind of payment. So it became because there is a huge demand which was addressed, and so it became instantaneous success and runaway success, I would say. So we have today 600 million ABHAs created. That is, ABHA is a patient ID, unique patient ID. But how many of these 600 million are using it at least once in a month, etc.? If you see, the number of PHRs created is much less. That means people are not even using once in 2 years. It's only for record's sake. But how can we turn it around and really make it as ubiquitous as, say the UPI, etc. There, the question of again governance and partnership that Kiran was mentioning plays a role. How do you incentivize the private ecosystem to really, even in the UPI, you know, the greater part of the role, only the platform, the concept was created by the government, and it is the Googles of this world and it's the phone pays of this world that have really made a huge difference. So how do you, you know, create that? Then for which we need, of course, a few killer applications. What are those killer applications that people drive, people chase? We don't chase people, people chase us to have those applications related to health, and this is very important. Awareness building is very, very important there to chase that value. People realize that value. Once people realize the value, you will have a, you know, UPI-like thing in the health sector. So one last point on this side is also the need for a, you know, a very effective system of ecosystem of data exchanges. Today we have a single health information exchange operated by the NHA. Is it sufficient? It is necessary, but it's not sufficient. We need to have a network of easily accessible health information exchanges where people can really, you know, just as we use email, people should be able to create their PHRs just as easily as they can create their email accounts and you know, send communications. So net on the adoption side, it's a collective effort, I would say, but net we need to look at both supply side and demand side activities and press the pedal hard on them, and make it very easy for the doctor ultimately to, you must conquer the doctor and you have conquered the digital health. So that's what I would sum up the first issue that Kiran posed to me. The second, I think it's a question of time. I have no doubt that all these Abhas will be rich with PHRs. The PHRs will be at least 10 times in number than the everyone is using the PHR at least, Abha at least, you know, 10 times in a year. That should be the goal. Now, the second question, which is really, again, a very large, expansive, emerging area, responsible AI is what, because, you know, innovation cannot be stopped. It goes on, and it doesn't depend on anybody's mercy to flourish. So innovation, and one of the key things today is the AI part. So especially in the context of healthcare domain, where the information is super sensitive, and the result has got to be 100% accurate. It can't afford to be any leeway for any kind of correction, etc. So responsible AI is extremely, while it is applicable to the entire spectrum of you know, activities in which AI is used, but more relevant for health sector, because a damage done to health or a life lost as a result of a wrong decision cannot be regained again. So I would say that, you know, there is a, on this I must say that the whole school of thinking around RAI, in fact there is a RAI institute, there is a exclusively dedicated to responsible AI. Infosys, for instance, several companies have got you know, special divisions on this RAI. Infosys being the largest, and I have attended a few of their, you know, events. So what is RAI? What is responsibility in the first instance, in the especially in the context of health, is that it should empower people and impact positively the individuals and the society in a equitable manner. That is RAI. It's not only giving the benefit, but giving the benefit equitably to the big and small, as you can call it. So there is a definition this institute has brought out, and that's important for us to. Those who are interested may kindly see the institute website and learn more about RAI. Now, it is founded on a few principles which are all applicable to the health domain, which is, for instance, the validity and reliability. There are 7, 8 principles. I will say a few of them. Reliability of that. You can't say, oh, sorry, you can't undo. There is no undo button in health. You have prescribed and given a wrong medicine. You can't press the undo button. It has gone into the system, right? So that is very important. Reliability, 100%, accuracy in what AI we do through AI. Second is safety, the physical safety of the person as such. Accountability and transparency in what we are doing. It's not that, AI has told me this, so I'm doing this. I should be able to explain it, and the physician should understand clearly what's being told. Explainability and interpretability of the algorithms that go behind. We have used, for instance, in the World Economic Forum, we created a framework called FAST Healthcare, and which is called Fourth Industrial Revolution for Sustainable Transformation of Healthcare. It's a long name, but first healthcare, and within that first cancer care is a framework for treating cancer, managing cancer in an effective way with the government of Meghalaya, which has taken that framework and implemented effectively. So there AI was used also for breast and cervical cancer, early detection, and we have some positive evaluations of that project. One entire district, which is dubiously called the cancer capital of India, which is called East Kashi Hills, it was done, and government is now extending it to more districts. But to cut a long story short, the implementations of AI, in real time are happening as I speak, and here, what is required for RAI, responsible AI. A few things I have noted here, which is from there is a lot of literature. The World Economic Forum itself is working. We have an initiative called AIGA. Those who are interested in deeper study may please Google and find out. AIGA in the World Economic Forum site, AI Governance Alliance. It's an alliance of about 500 governments and private sector bodies, AIGA. For the last 2 years, we have been working and released a series of papers, almost about 10 very serious papers are available there, white papers on this subject. So that's what we are doing on the RAI as a global initiative. And to address another point, which is the data bias also is one of the, apart from other things about responsible AI, it also the ethical part of it is how good is the data. So there is also a very nice framework for addressing issues related to data bias, algorithmic bias, etc. In the interest of time, I won't go into further details of this work, except to request you to please have a look at the site on the AIGA, AI Governance Alliance. So with that, I would, because 2 heavy points have been given, one is about adoption, and a totally other side is the AI. So I hope I had to really fly through these 2 subjects.
Sure.
Thank you.
So, I mean, just to bring this point home, I'd just like to have a quick show of hands. How many of you have put symptoms that you think you're facing into a chat GPT or equivalent and checked for things? How many of you believe that it gave you an accurate answer? No, nobody. I'm surprised. I believe that it gives me very accurate answers. And I think that is, the core problem. Our implicit trust in these generative AI, where we are putting it in and then we are going to probably follow through. And I think in mental health, I think I was reading one use case where it was misdirecting some young people towards suicide actually. So it can really go, and all of this is going to be in our lives. I think like you have been using Google, I'm sure that many of you are using ChatGPT at least a few days in your life, and you're starting to implicitly think, this is part of the tool set that I'll use for my life. But you don't really understand, we all still, as a society, we still don't understand what directions it can drive us. And so the work that happening on responsibility AI especially, and what's the role that governments really have as these new health technology emerges, I think is a key area. So thank you for sharing some insights, sir. Yeah, very difficult space. We're going to move to Dr. Smisha.
Kiran, if I could just come.
Yeah, please.
Okay. I think we are honored with the presence of Mrs. Madhuri Kanitkar, retired Lieutenant General, and she's the Vice Chancellor of Maharashtra University of Health Sciences. One of our best, Nishant, works with them on the Maharashtra project. But not only this, yesterday I was with Rizwan, and we were talking about NABH, some standards for early childhood development. And I was saying, look, Rizwan, we have people either who are digital experts like you, or there are people like me who are physicians. But we don't have a digital health expert. And when I was in medical college, nobody taught me what is digital health. He says, hey, we have done something with Maharashtra. So I think, ma'am, I'm sure Nishant will be catching this up and sharing with us as a whole. Ma'am, we would like to replicate this across Asia Pacific. We do not have a digital health courses. I am told you have courses ready to be taught in the medical colleges on digital health, which actually will be one of the first across Asia Pacific. Ma'am, mic to you.
No, please. Very important topic.
Thank you so much for singing, and I really appreciate Satyanaraji putting in that doctor. I think it should be 4 Ds. The demander, that's the patient, to the doctor, to the data, to the diagnosis. So you need 4 Ds, and I'm extremely happy to share that not only have we got these courses ready, so our Digital Health Foundation course that we developed with the help of Koita Foundation, and it's on our LMS website. It's a credit-based 2 credits with 13 modules and an virtual sort of EMRs of about lakhs of patients, so we can give exercises. And made just as a thing, carrot and stick, probably the military this. I made it compulsory for interns, and as of date, I've got 6,000 interns doing that course under MUHS. And then when we shared it with NHA and put it onto the iGot platform, till March end, we had 60,000. So that's the thing, and I would be very happy to say we have 2 other courses ready. One is launching in June for the nurses, and we've already tied up with the Trained Nurses Association as well as the Indian Nursing Council, so that it will be launched, because first thing is capacity building at the grassroots level. So I really appreciate that, and that MUHS did think of the same thing and then get into the next level. Our certificate course is getting launched this year for doctors, by doctors, because moment you don't bring doctors on board and you create a course which is technical, it puts the doctors off because it's jargon. But the moment I talk about it with my students, they say, okay, we can do it. So I think that's and I really thank you for that.
I might also ask Rizwan that he told me about the nurses thing. I said, the next step should be frontline workers. And he says that is perhaps not his mandate. Ma'am, I'll nudge my colleague Nishant, that Nishant, if we can get this done as part of your project for frontline workers to a digital small health course. You remember when we were trying to launch Ayushman Bharat Day and all, Ashas and Anganwadis, they actually struggle to use the digital tools. So
I'd like to add this. I discussed this with the previous secretary NHA, and I called it give even the Asha worker a choti si Asha. I said give her a chat buddy, give her a AI tool which helps her and it's very easy now to convert it into every language, every dialect. So I said that is the thing, and I'd be very happy to help on that initiative.
Thank you, ma'am. And I think very, very relevant, given that Dr. Satyanarayana was talking about the importance of getting doctors as a key adoption thing. Dr. Smisha, I want to move to you. You have been running this global exemplars for digital health across many countries. We would love to get some insights from you on what are the key learnings that are coming out of that study, and also what really in your mind hinders promising digital health solutions from actually getting to scale, and what should be governments or funders being doing about that?
Thank you, Kiran. And so just maybe as a little bit of background, I'm a professor of digital health at Johns Hopkins, where I direct the Center for Digital Health Innovation. And as part of this effort, we've been around for about close to 20 years right now. And as part of this effort, more recently, so we typically do controlled trials or studies of digital innovations globally. And they range from innovations that are targeted at clients, so direct to consumer type like apps, but largely on service delivery transformation. So how do we transform frontline service delivery digitally, whether it's for community health workers, facility workers, district planners, or systems like logistic management system or human resource management system, and or telemedicine systems for that matter. So more recently, with the Gates Foundation, we have been looking across 5 countries that are at different levels of maturity. The countries are Rwanda, Ghana, India, Brazil, and Finland. And really, we take a retrospective look. So we look back 20 years to try to understand what did the countries do to then effectively transform their primary healthcare services digitally. And because we have a country like Finland, which actually does have 20 years of rich history, work started over 25 years ago there, we are able to see not only what they did, but the mistakes that were made, the corrective actions that were taken, and in conversation with their leadership, we're able to identify what can others learn from those mistakes, right? So that we have a shorter runway as we are trying to approach digitization of these services. And perhaps since the conversations also revolve around AI, we also test several AI-based innovations. So things like Kiran was mentioning, suicidal ideation in chatbots, in conversational agents, where a user, because we can't determine user behavior, right? So if a user decides to, let's say, confess to a chatbot that they have suicidal ideation, what is the ethical responsibility of a chatbot? What should the consent look like for a system like that? Anyway, so going back to exemplars and Kiran, to your question, there are, of course, a number of insights from across all of these countries, and several of them actually have already been outlined by Satya sir and Dinesh. Perhaps I'll try to speak to the ones that they haven't already spoken to. I think they've talked about the nuts and bolts of what needs to be there and what's been part of the ABDM ecosystem in India. I think, broadly speaking, governments often struggle with the idea that should they be the provider of the digital service? So should they be developing the applications themselves, or should they be the provider of the platform? And what we've seen is the countries that have scaled are the providers of the platform, like we are in India. So ABDM is essentially a platform that allows integration of multiple apps and services. But by the government providing this digital public infrastructure, it's providing kind of this layer that others can plug and play with. And so that is actually quite transformative and it's also a large-scale investment that governments can make. It can spur private sector investment too, because then there are rules of engagement that are well defined, and private sector has sort of guidance of, okay, the government has said that we need to follow certain standards to exchange our health data. So that's perhaps one of the insights. I think the workforce issue, people have spoken well, quite a bit about. It is perhaps the largest barrier where many countries, if we look at, let's say, the history of the National Health Services in the UK, in the United States, they're all terrible examples of digital transformation, right? Because they've made tremendous investments and then just not had uptake by doctors. Because let's accept it, the large majority of our doctors are typing information with one finger. There is now a screen between the patient and themselves. it interferes with clinical care. It breaks actually the provider-patient relationship a little bit, right? And so there has been resistance from doctors who now spend hours. I think in the US, they predict that, that the average US physician spends 5 hours daily entering notes, right? Primary care physician, 5 hours daily just entering patient notes. So these are very real challenges, and the fix is not a quick fix, right? The fix is it has to be integrated with pre-service, in-service training for doctors and allied professionals. But that's often one of the biggest, I think, barriers to scaling up. Another maybe related insight, I'm trying to not speak to the issues folks have spoken to, but is around procurement. Again, not something we think about very often in the maybe in the sort of traditional healthcare sector, but how one of the biggest challenges of digital health is that it brings the technologists and the health people together. Now think about a Ministry of Health. The people in a Ministry of Health know health, right? They are either physicians or public health professionals or allied health professionals. The technologists speak very different language. When they try to come together, there's often just a simple break in communication. There is also another reality that most of the biggest drivers of digital transformation in the health sector come from outside the health sector. So for example, if you look at in India, Aadhaar, right, UPI, they have actually driven the health sector transformation, but they've not been within the health sector. So the success of any health system transformation is actually highly contingent on the non-health sector, and that really brings into question about how do we govern the digital transformation? What should this governance structure look like? How should we collaborate across different sectors? And so we recently had a meeting with ministries in Rwanda, Finland, and Brazil, because they have different models of governance. And so we're able to look at sort of what those models of governance are, and we're also able to see that actually our governance evolves as the maturity of our ecosystem evolves, right? So it's not a one-size-fits-all. It's also not a static governance approach, but that's really critical. I think as far as sort of the success of direct-to-client interventions goes, so these are apps that are consumer-directed. It's a little bit more straightforward, but contingent on also collaborations with, we do need 3G, 4G connectivity if we are trying to drive, equity-based adoption. And maybe the last point I'll make is thinking about financing. And I think this has been one of the prime examples from Brazil, where the financing of digital transformation has come from the primary healthcare services, and they have incentivized. So in India, we are incentivizing transactions. We are incentivizing the transfer of health data. In other sectors where this has truly worked, they are incentivizing the infrastructure. So do you actually have computers? Are you able to maintain them? Do you actually have people? And only if you meet that threshold for the infrastructure needed to actually drive digital transformation, then the incentives are provided. And so the personnel and the infrastructure is what's incentivized. And so the biggest impact it has had is that we see that that in more rural and poorer areas in Brazil, there is better adoption of digitization because of that incentive structure. And so it's reversed this sort of idea that digitization can't reach the last mile because the incentive structures have tipped that. So thank you.
Great, thank you. I think I'd love to, the two things that struck me, that the need for innovation varies, right? Like you were talking about how in the US, 5 hours for physician for filling notes. Most of the time when I interact in India, the doctors are telling me, can I finish for a patient within 30 seconds, right? So all they want to give between two patients is 30 seconds. And so, I think the innovation side has to happen on both sides. And I think the second point is a great thing for, for me to take forward with Pradeep, because it is true that when you bring health technologists on one side, doctors or policymakers on the other side, and procurement being a challenging problem, it is one of the key barriers to adoption of digital health in many, many countries. And so Pradeep, you've been running the Health Innovation Exchange, and I think you have been working with digital health innovators on one side, with policymakers and with funders. So tell us about what that journey is looking like, what are the challenges that you're seeing, and how's that progressing?
Thanks very much, Kiran. I'm freezing here. I just realized Delhi has this 40 outside and 14 inside, so if I'm a lot of wise people around me, I should have followed their thing. So anyway, I think it's maybe just a little bit. What we do is we work mostly with countries in Africa, with ministries of health to a large extent, advise the ministers on what they need to do in terms of the digital transformation, where should they be investing, what can they invest in. So that's predominantly what we end up doing. A lot of issues that have been raised. One, what are we investing in? Usually we end up investing in what is sexy and AI and chatbots and things like that, but we don't invest enough in the fundamental infrastructure, which Smisha also mentioned. 50 to 70% of the health infrastructure does not have electricity, okay? So where can that digital transformation happen? It cannot, right? So, and then, I don't know how many of you have been to many of these places. I mean, I know, I remember that in the good old days in India, but we are so far ahead now. But in most of these countries, I remember sitting with ministers. They'll say, give me 1 minute. They'll go behind their computer, press a button, come back and sit down, happily have tea, and then go back, and still there'll be the file which is downloading. And it's small files, right? It's not even huge. So we don't, what is happening to a large extent in LMICs is that we are not investing in some of these absolutely essential fundamental building blocks. That's one big challenge which is there. So number two is we are investing in individual solutions and not an ecosystem of solutions, okay? Any one tool has a certain level of ability to deliver results, but unless they come together, you will not have the impact. And that's where India has done a fantastic job in trying to bring some of these tools together. Let me ask you a question. Do you know the number of digital tools that are launched in health? What is their life expectancy? How long do they last, and what percentage? Okay, let me give the answer. 2% of the digital health tools that are launched survive over 3 years. The rest of them disappear along the way, okay? And that is a huge challenge, because what we're doing is, we all love this flashy stuff that we do, but we're not really investing. So what it has done, and I'm realizing I shouldn't go too long, so let me say 3 things. One, what it does is the risk in investing is so huge that we have not, and also the scale. How many of the applications, how many of the health tools have really become unicorns when you start looking at digital health? Very few. Very few. Yeah? And what it does is, if you're an investor, and I'll say something about the development financing in a minute, and I'll probably have Dinesh kill me now. The investing, if you're an investor, you're not looking at investing 1 million, 2 million. What you really want to be able to do is to invest significant chunks of money, yeah? So that otherwise, when you're if you're investing in a 2 million fund or a 2 million entity, or a 20 or 100 million, the effort involved is the same, right? So that we are not able to provide innovations that can be on scale, because we are all looking at these micro investments and then everybody. And the reason for that is that you spoke about why people use Booking.com or Uber or any of those things. Why do we not have something like that similar in the health sector? It is because of all of us from the development world continuing our development financing models, where we are saying, okay, we'll give you a little bit of money here. But what we are doing by that is we are taking away the hunger from the market, and we're not really helping to drive that. How much of free money did Uber get when they were setting up? Or Ola, or any of the... So I think we need to really make it, profit is a good word, we should not be getting away from profit. And where you need to do is the regulatory aspect, you need to really be doing a lot more. And that's something which we are failing. And maybe you touched on procurement already, so I won't go down that. I think what we really are finding and what we are really pushing, and that's where I got into trouble a couple of weeks ago by saying what Trump did is the best thing for the development sector. I know I'll probably get beaten up by others, but fundamentally, I do believe that if we want to drive the health agenda to become much more sustainable, you need to bring back some of the basic fundamental principles of investment, investing for returns and sustainability. I'll shut up there. I don't know if I've answered your question fully,
Yeah,
but I just wanted to highlight some of those issues.
Yeah, thanks, Pradeep. And I think it's a good segue also. I think, Dr. Smisha, you were talking about how sometimes many of these innovations for the health sector come from outside the health sector. I've recently been working in Nigeria and been looking at PHCs, and I think over 80% of the PHCs I think suffer from two things, right? So electricity, stable electricity, connectivity. Without those two, where do you start on digital health or anything else? And those are not, in many ways, not the health sector's primary, in the control of the health sector in many ways. I'd like to move to Dr. Angela. And Dr. Angela, you've been working again with communities, many of them, marginalized, and especially on the last mile across APAC. What has been your experience in the use of digital tools? Which are the two kind of tools that you're seeing are quite effective in those environments? And on the policy side, what do you think needs to happen to, say, really get to adoption and scale of some of these tools?
Sure. I might answer a different question.
Okay.
I mean, I think if speaking about the power of digital health, for me, it's really power of people. You don't get data if we don't trust the people, meet them where they are, understand who the people are. My work is largely with invisible communities. And when I say invisible, these are what you were mentioning before, right, in the introduction, the underserved communities. Why are they underserved? Is it because the health system doesn't see them? And if the health system doesn't see them, they're not designing for them. And then we're talking big data analytics, but you're missing out a lot of real data. So for me, if we invest in the power of people, then only we'll get good data, and then only we'll get doctors who can make sense of the data, and then we get good diagnosis. So my question to me would be, how do we do that? What are some enablers, and what's coming in between?
Maybe you want to talk about examples of some of these invisible communities.
Yeah, I mean, yes, and we were, I think some mention was here before, migrant workers, street vendors, people who you see and you buy your fruits and vegetables from, but do we say, hey, let's strengthen primary healthcare. Do we really think someone who's trying to just put some food on the plates of their children have the time to go to a PHC when they have a headache? They don't. They don't go to a PHC unless their livelihood is at stake. They wait till they're almost going to die to go to a hospital. So primary health, the understanding of what is required by the people is failing. We are failing the people by setting up the centers and saying, you come to us. Where will a construction worker walk into a PHC? Where will a sex worker walk into a PHC? Do we see transgender people standing in line to go to a PHC? We don't. So how will these people access PHC? Do we understand them? Do we meet them where they are? So technology has to meet them where they are. What are simple things they use? They use phones to call their loved ones. So they will use the phones. Missed messages. I think we had huge success with TB, with the missed call, and continues the missed call system. So there are still simple things, voice messages. Farmers are making transactions on livelihoods by using technology. But is a health technology augmenting into those systems? Like Dr. Dinesh said right in the beginning, that health is far behind. But then what can we learn? Sometimes it's good to not be a first mover. You can learn from the mistakes of other sectors. But do we then take the learning from those sectors and say, we didn't think about it? If you talk to marginalized communities, and that's pretty much my work, health is 7 in the first 10 priorities. First is livelihood. Second is safety. So how can we, weave ourselves into that space? How can technology, weave into that space? Then comes my favorite subject of frontline health workers. We are trying to create parallel system and dumping it on them. I have seen the apps that they use. I would never use those apps. They're horrible. But they do use parallel phones and other things to do their daily jobs and meet their loved ones. Why don't we make it simple for them? Why don't we augment stuff for them rather than create parallel systems? Second, we tell them, we give them information because now we are the doctors, we have the information, we must know what's right. But we don't actually engage them in the design of solutions. So the ones that have worked, there are apps that have worked, are those that have gone to the ground and designed with the people of what works for them and augments their work that they're already doing. It has to be easier. The work has to be more efficient. It has to be effective, and they have to get it back. What do? We just extract data. I work with the district health administrators, district collectors. They said, you people only take data, but I don't know what to do. This is my data, but I don't have actionable insights. That's true. So how does the loop back go in, and how does it make sense? It can't be like super scientific and super medical, and we don't need to show each other that we're very smart and qualified. But we need to make it work for the people. So for me, the power of people is really important, and the technology needs to meet people where they are. People don't need to meet technology where it's getting at. So I have a lot of hope for where we're going with AI, etc., but I don't want it to become exclusive and exclude people who really need them. So I'll stop there.
Thank you. I think great points you made about having to design with the people and really make sure it's useful in their context. I'd like to move on to Manish. Manish, you're part of a large medtech player, and I was introducing you saying that you guys make everything from cardiac stents to diagnostic devices. But tell us a bit about, in your experience working with doctors and products, especially in low resource settings, where are you seeing technologies, and including technologies like AI, kind of make a difference to the type of medical tools and systems that you're able to bring out to the market?
Thank you very much for inviting. So if we look at India, I think the recent NASSCOM report has actually said that about 70% of our population is in rural and smaller cities, suburban places. And vis-a-vis, if we look at where is the healthcare infrastructure, 80% of it lies in cities. So hence, coming to this topic where we've kind of interact with doctors and all. So now is the time for digital health and AI straight away. It's not anything in future, but it's right now. So that's the basis. And then just to talk about what does it do, while we are a large Indian multinational, we talk about access, accuracy, and affordability. These are the three pillars which actually get addressed by both digital health and AI as a combination package. If I have to talk about access, again, an example where, a simple X-ray, imagine an X-ray is a very small technology available in villages. One could do, but does a radiologist have that kind of expertise? Because the good doctors want to come to cities. They don't want to be there. And so that is where we talk about access, because he can just put it on a app and then the results are already there. So this is where I'm talking where Satya sir said that it has to be easy to adopt and not complicate things unnecessarily. So that is how the access part has to be or gets addressed. Talking about accuracy, yes, these AI apps are absolutely very accurate. They do see something beyond just the X-ray because of the big data which is involved, and we see that this big data is now really the clinical currency, what we say. So that is something which creates this kind of an accuracy. Then obviously, these are some of the things when we talk about data to diagnosis. The diagnostics are done with the help of AI so that it can predict a lot of diseases and things. So that is where the affordability factor gets addressed as well. So that's 3 A's. Just a little bit about, as Pradeep just said, that just 2%, what was the statistics? 2% of the apps have a life of 3 years, and I definitely agree to that. But yes, yet I think we are at a stage where we want to, and we are building lots and lots of apps. A little bit about what we do, and as a private organization. We have a organization within Merrill called as Nuvo AI, and Nuvo AI Private Limited is an organization which creates a variety of apps, and these are all, like, it's a team of more than 100 odd engineers, all from IITs and NITs, and they work day in and day out. And there are few apps that are developed, and there are certain who are which are in still the developmental phase. So just to reiterate the same thing, like we have an app called Radio IQ. That's an app for, again, X-ray detection and finding some of the diseases. For example, this Radio IQ, if an X-ray is shown on the lungs, you can predict like a pneumothorax and various other lung diseases. They can be predicted well in advance, or cardiomegaly for that matter, that can also be predicted. Likewise, there is an app called OphthalVision. This is a very unique app, and we talk about access, how does this technology go to remotes and all. There is again this statistics coming wherein there are about 11 million population. There's about 11 million population in India, which has one or the other retinal disease. Now, how does one address that? So there's a small device that we've made called OphthalVision. It's an AI-driven device. You just take a scan, that's it. It can predict the diabetic retinopathy or age-related, the muscles of eye becoming weaker and stuff like that. That is a very powerful thing, because if you can predict this, then you can already treat that. And as I said, access, it's a small device. You can go anywhere, villages, small places, cities, towns, everywhere and anywhere. So that's another thing. Likewise in the cardio sector, because almost, India is a capital for CVDs, the cardiovascular diseases, cancers, diabetes, and so on. So diabetes relating
to... With our population, aren't we the world #1 on most diseases?
So likewise, cardiovascular diseases. I was reading some statistics recently that 270 million population in India is currently under CVD threat. How does one address that, or like how do we predict? So, people say do a CT angio and you will know what it was little before and little later. But so there is a app that we've developed. It is called as CardioVision. It is going to tell you two things within the heart. If I say that there are coronaries and there are valves, so for the coronaries, it is going to tell you exactly the blood flow, how much it is restricted because of the plaque and so on. So what is the risk, how sooner or later is the risk, is something which can be forecasted by this app. Talking about the valves, there is something called as TAVI vision. So this is like a trans-aortic valve replacement. TAVR is a very common procedure these days. Can the heart actually be treated with a TAVR? If yes, then what is the exact placement of the valve which is required, and what is the size of the valve, which is very crucial. So kind of a surgical plan is already devised in place. So likewise, we are also into robotics and AI. Now you might think robotics, but yeah, this is not like from data to diagnostics, diagnostics to treatment for ultimately better patient outcomes. But all these robots are also built with AI, a lot of AI in fact. So there's an orthopedic robot which has become kind of tool in all the orthopedic theaters across India, and then will transcend across borders very soon after the certified European approval as well. The moment there is a CT scan done, it already gives a complete plan. That's how the AI is applied to it. It will be classified into 9 different things, and there's a classification available which the orthopods understand. And you can straight away get the plan and execute it, implement it, feed it to the robo, and that does the whole surgery. So those are some of the things as enablers that we use.
So
and just
Manish, quick question on that. Should I be encouraging my kids to become radiologists, or their jobs are at risk?
So madam will say no, and I agree to that, because ultimately at the end of the day, the people are very important. And when they adopt it, they can only use that as an adjunct and really make it really, really fast. I know a lot of physicians, in fact, as you said, they want to finish something in 30 seconds. There are these apps which are available. So while the doctor is seeing the patient, he just dictates and everything is typed. By the time the patient is out, he gets the report in his hand. So those are things which are, and I'm sure Dr. Dinesh will acknowledge this. So these are things, long and short, we should not look at digital health and AI as a real technology gamut or something like that. It's not a big technology anymore. I think it's a need of the hour. That is going to help us make sure they bridge the care pathways, care gaps. And at large, as an organization, we believe that these technologies will be available, and we want to democratize these so that the patients, no matter where they are from, they are benefited by this. Thank you.
Thanks, Manish. Dr. Dinesh?
I think, let's not demonize also that AI is something which is not being used. One of the unsung heroes is our TV program. The Nikshay app is fantastic. We have Nikshay Mitra where people can volunteer, Nikshay Poshan where the money is given DBT, Nikshay Partner where the private hospital people can just upload data. And in fact, we have gone ahead, and yesterday me and Pradeep, we are discussing with Government of India, universal scanning of TB patients across India. They are discussing with handhold X-ray and AI tool. And the report comes in less than 30 seconds. And I'm told it's better than seen by a doctor. Yeah. And it's a health systems approach. It's not only seeing TB, but any nodules, any cancerous lesions can also come. So I think this technology will percolate, and we will need to have more of a health systems approach, but AI and digital will have its role to play.
Super, great this one. So I think, Madhu, you've been sitting here at the corner of this panel, listening to everybody else, and you work a lot with governments, especially on the policy side. So wanted to get your perspective, what would your key takeaways be from this session? And, which you think you can actually help to shape the future of digital health policies?
So I will summarize my 2 pages of notes in 7 points. And because I stand between the freedom from this session, I'll keep it very, very short. I think very important, and to the Ds, I think I would like to also add another D, the danger of it. Not to sensationalize, but I think there is, and it comes from the danger of inequity that Angela was referring to, the danger of exclusion, and where is it, what is it guiding towards? So I think just one D, and I think from the policy, what Dr. Dinesh said, you have to get your problem statement right. I was listening to the NHA experience, and unless you get that problem statement right, I think jumping to the product and then saying here's the solution is not going to be. So that's one thing, at least it came to my perspective that yes, we should try and invest some more time on the problem. Second is give independence to agencies which are investing, be it on the private side, on the public side, who are trying to provide solutions, who are trying to implement digital heavy programs, because while it is established to some degree, there are still a lot of unknowns, and unless we are open and willing and we empower these institutions with a degree of independence, with a degree of finance, we will probably not we will probably not be willing to take the red pill, right? So we have to embrace the matrix. So so that independence for the institutions is something that I felt has done well for NHA, and if that is sustained, it's going to be good. The two interlinked themes that I felt emerged was of simplifying and adoption. Be it simplification of regulations, as sir you were referring to, be it simplification of user interface, be it simplification of what are we financing, or withdrawing of it, as Pradeep was indicating. But yes, I mean, simplifying, making it a pleasurable experience, as you said, for everyone, for the doctors, for the users, for the policymakers. So yes, how do we, while of course, you cannot, while not ignoring the complexity of the health systems that it is solving for, but yes, I believe that simplification is something that is closely linked to the adoption part of it. And if I may, I think we should also equitify. It's very, very important because most of us probably will not experience a lot of things that we are solving for. And most of us probably will not always reach out to those who are we solving for. So it's very important that, to keep that last man standing in the, or woman standing in the queue as one of the principles, I believe is going to be very, very important. Last two bits. One is incentivize collaboration, because there is enough evidence coming from the experts in this room, from outside the room, that not all the solutions are with the health sector, not all the triggers are with the health sector. Often the ideas and the solutions and the way forward will come, and even Kiran, you were referring to that Aadhaar. So some of it will come outside of the health sector. So we need to incentivize, collaborate. Otherwise, ma'am, as you said, unless there is a carrot and stick, why would people come together? And lastly, the bit that I think is we should not forget is that yes, all of this would build on the basic fundamental infra, basic health systems. We can't be building castles in the air without that electricity and that water supply and that building in the place. So those were my 7 key takeaways. I hope.
Great, excellent
useful.
summarization. Thank you. Well, I think you did add a D of danger in it. I'm an eternal optimist, and when I look at the future, I still see that I think we all usually, in the face of adversity, we always all come together to solve for it. I think that's the power that we normally see. COVID is a great example of how we saw all of these disparate. Sometimes you can look at life and say there's so much negative going on, but mostly I see the positive side, and I have great hope in the future of digital health. So thank you all panelists. We have a few minutes for questions. So if anybody has any questions, please.
Question.
Can we have some?
All the key
Yeah, please, sir.
Yes, D2D. This
National Digital Blueprint.
Yeah, D2D means data to digital or digital to diagnosis or data to
we
diagnosis.
had a lot of D's today. We
Yeah,
added
lot of
doctors,
D's
we
are
added
there.
danger,
Yeah,
demand.
Yeah, a lot of D's are there. You rightly said the data protection, data act, so many D's are there. And this D is very, very important. And all these datas, the patient, all records are linked with the Aadhaar. How it is saved under the DPDP Act.
Can be
This is very important.
on the same server.
Satya sir, you want to take that?
Out.
And second question is the data storing, data collection, storing, and use of sensitive healthcare data. How it is secured. And next is the capacity. The capacity to store by the healthcare center and capacity to share with the patient. Our all mobiles have the limitations, how it can be. You rightly mentioned the rural areas, 70%, connectivity. And you also rightly mentioned the power, continuously supply of power, and the uninterrupted the signals. That's all.
Thank you. Satya sir, do you want to address that?
Yeah, I will address two of these questions. First one is, how can you link all the health things to the Aadhaar broadly? But I think it is not designed that way. The ABHA, which is Ayushman Bharat Health Account, is what you can call a derivative ID. It's not a primary ID, it's a derivative ID, derived partly from Aadhaar and partly from other IDs that people can submit. It's not necessary that, that to create ABHA, you have to give your Aadhaar number. You can give any of the listed other identities and still get your ABHA. So that way, and then having generated ABHA, there is no further linkage with Aadhaar any longer. It is only ABHA that is used going forward. So it's a ring-fenced area, right? ABHA ring-fences your health records from any other thing that happens with Aadhaar outside of that. So we made it absolutely clear in the NDHP itself, National Digital Health Blueprint, that there should be a way of a derivative ID, and then afterwards you are delinking. It's like an umbilical cord, which is dealing from the mother and then nothing to do physiologically with the mother. We can roughly imagine like that. So there is no risk of any kind by using ABHA. The second part is, how can people store the health records which are bulky, which probably not even our best cell phones cannot, smartphones cannot handle it. Yes, you're right. So the provision for that in the architecture that we had designed in the ABDM, we can go back and see more details, is the category, a new category of service providers has been suggested there, which are health data repositories, HDR. You can see that also in the ABDM website, where just like email service providers, you have Yahoos, you have Gmails, you have several other email providers who kind of handle your data once you subscribe to them only one time. So likewise, the health data repositories, people can subscribe to that and then see that their records go there, and then create the longitudinal health record, PHR, whatever you may. So that is the answer of storage. You don't have any, if that really we play that card well, encouraging a few of the HDRs to come up in this country, maybe 10, maybe 20, whatever it takes, the demand requires. So that is the ultimate position that, people need not be, you can rest assured, even if you lose your mobile phone, nothing happens. You can just go recover it from the cloud, as it were, from these HDRs, which are highly regulated, and your data, health data, which is so sensitive, is safe and secure and under regulation. So you can trust, you sleep well. Yeah. These two questions I can answer. Yeah. Yeah. And others. Yeah.
We'll have. Can we have a question from the please?
Morning. Thank you to the panel. It was very informative discussion, and I had just one question. That where does the I really didn't follow the argument. Where does the investment have to come from this? Because we see a lot of inequity, which was talked about. The invisible population, the 60% rural, the significant population below poverty line. All technology brings some cost to it, and already health is one of the leading causes of poverty in our country. So where does that additional investment come from today if we want to implement our solutions today? I come from a charitable sector. Sir, I appreciate the issue of making profit. It's not a bad word. Even the charity sector makes income over expenditure to spend on charity. But what horizon to this profit also? That's another question I have. Thank you.
Sure.
Thank you, panel, for such an enlightening session. I'm Dr. Prasad, resident doctor from Maulana Azad Medical College. Ma'am, I had two questions. One was answered by Madhusudan sir. I would like to point my question to Angela ma'am. Ma'am, you emphasized on that on that we should design to meet local people's need. But one of the major issue with this is that with the data from AI is that there is a problem of standardization of data. So who did not add more to the problem of standardization of data?
Yeah, I think Pradeep, or do you want to take the? You have one more question? Yeah, please.
I think I'll just pick on the where the investments come from. Yeah, I think if I may, sir, basically I'm not saying that we should not be investing in anything. Completely take your point. What I was really addressing is that we end up providing these little life support, but we are not doing enough for these innovations to flourish. So we need to invest on scale rather than what happens is that you end up putting 100,000 and 1 million here and 2 million there, but we are not investing on scale. And that resource will not come unless you really look at making it attractive for the market. And we can certainly have that conversation offline, but I do believe that we need to invest on scale, and we should not end up creating these. I mean, I'm a great believer, let 100,000 flowers bloom, but unless you really tend to it, we are killing everything along the way.
Dr. Angela?
We are not going to collect uniform data. We want to understand the people for whom we are solving a problem for. And there's enough technology to be able to capture that if we only design it with the people. And one of the things that I wanted to share is we've spoken quite a bit about physical infrastructure and capital infrastructure, but we missed out social infrastructure. What happens when the phone is with the man who's earning and left the house and gone to the fields? What happens to the elderly people at home? What happens to the woman? How do we get digital anything, forget about health, to that? So I think in terms of what we're discussing in like planning, programming, designing, we must bring social infrastructure into the game.
Thank you. I think we are out of time, and if anybody has more questions, I'll encourage you to meet up with the panelists, outside, and request all panelists to get together for a photograph. Thanks, everyone.
Can we have Mrs. Ayako on the stage for a photograph, please? Can we have Mrs. Ayako? Miss Ayako, can we have you on the stage, please?
Hello, check, check, check.
Check, check, check. Hello, hello. Check, 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 check. Hello, hello, hello. Check, check, check. Check.
Hello.
Check, 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 check,
Check
check.
है ये वाला.
Check, hello, hello. Check, 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 check. Hello, hello, hello.
Hello, 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 hello.
Check, check, check. Hello. Hello, hello. Check, check, hello, hello. Check, check. Check, 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 check.
Welcome everyone. Two minimum criteria have been met. A, all my panelists are here. And two, the number of audience exceed the number of panelists, so we are good to go. So what we're going to do, and I request all the panelists to join. I will do formal introductions later on as I move to the panel. So the way we have planned this is that we are just coming from a session about India's vision for AI and scaling it for public health, equity, access, justice. Every time it boils down to one thing. You can't have better AI, you can't have better digital health until you have better data. And the trouble with data is there are two extremes one can think about. All data is easily accessible and usable, with little concern for protections and things like that. That could give you perhaps one version where innovation gets pushed to the maximum. But that's not a vision that any one of us have, right? On the other side, you would want to protect data, use it well, but there is always a cost. The more regulatory systems you impose upon the flow of anything, there will be costs to pay, both financial and in slowing down things. Our chair, Professor Ilona Cookbush, who I had the pleasure of knowing for many years now, she was the chair, and I was assisting her, for understanding digital health futures in a world where there's a new digital native generation coming. And we were realizing that data is the centerpiece of all this. Today's youth would be generating data at scale, always on digital platforms. And Ilona came out with a wonderful work that talks about a way of looking at data that is not necessarily this way or that way, but a right way to use data. And I think that viewpoint is something I wanted everybody to hear before we get started on the panel discussion. So she has many, many illustrious things to her credentials. She's been advising global health bodies for many, many years now. She's been an important part of advising policy all over the world, including Europe. And Ilona, no better place to start with you talking about your vision of data solidarity.
Thank you very much, Anurag. And of course, Anurag has not been really talking about his important role. He was the co-chair of the Lancet Commission. And ever since then, we have been working together, and we are now working on a follow-up project initiative with a consortium in Switzerland, here in India with Anurag at Ashoka, and with colleagues in Nigeria, that we have called Digital Transformations for Health. And I think this is also what we are talking about here, that it is not so much the digitalization of health and health systems, but that we go to the issue of data with the challenge of, will these data, how we use them, how we generate them, will they actually produce more health? Are they supportive of this vision? And it seems matter of fact, but if you go into the real world, you see that many people lose that vision along the way. And the Lancet Commission, and also our work now, has very seriously tried to push the issue that we need to do this on a value base. And that value base is, of course, also the value base of this conference, equity, but linked to equity is always the concept of solidarity. How do we share things, and do we share them equitably? Now, of course, if we talk of health data ecosystems, again, we tend to look at the healthcare system. We look at hospitals, community health, we look at doctors' practices, public health agencies, wearable devices, but also one point that the Commission made very clearly, health, if we're really about health, not disease, then we need to look at the data that are generated in everyday life. And that's, of course, what the big technology companies do. We talk about wearables, there's many other kinds of systems, But if we start from the premise that health is created in everyday life, those data become absolutely critical, but at the same time, those data, how much we walk, what we eat, our heartbeat, all those kind of things, are the basis of enormous profits. And in many cases, those profits are actually not taxed. So the profits of what you are doing in wearing an Apple Watch and generating data, first of all, goes to another country, point one, and goes to a private company. And we have not yet found an international system to actually address this issue of sharing of data, of use of data, and of all the ethical implications involved in that. And of course, also, if we look at the Sustainable Development Goals, the importance that we actually have data, and that's why they need to be scaled up, to know if we made progress. But even in the context of the Sustainable Development Goals, they have not really, when they were formulated, been ready for this boost in development of data. And they rely on data, but they don't say anything really how these data are generated, who owns them, and how we can best use them. And I think we really have to make clear to ourselves how extraordinary this power of data is. And I don't think also the international community has done that yet. And therefore, we are also suggesting that there needs to be work, particularly from the side of WHO, about standard setting, about data ownership, and particularly about data solidarity. Because we are ready to talk about solidarity in relation to healthcare systems, and different countries have developed different forms of solidarity for healthcare systems in terms either of public finance or social insurance models or other types of things. But they haven't yet fully done this in relation to data. So if we are on about public health and population health, then we also need to think about data solidarity. And here, of course, we also have that other new development. We know that data and digitalization are already radically reforming healthcare delivery in so many ways, and India, of course, itself is an enormous example of that. But what many colleagues are starting to work on is what they call precision public health. And that is that in the context of public health and population health, if we collect data in different ways, and if we are willing to share them solidarically in new ways, then we can tailor public health programs much more clearly to populations, and then we're with the equity issue again in terms of sharing the resources. So in this concept, as Anurag has said, that we have developed the concept of data solidarity, and I can just give you a glimpse of that. If you go up to the stall of Ashoka University, there is a special little section on the DTH lab, as we call it, and there you will see these little tiles. They will give you the link to the glossary we did on data solidarity. And that gives you an understanding how data solidarity relates also to other forms of data sharing, because there are such forms by patients, by institutions, etc. But also it's... who's that? The Tech Brothers? Who knows? But it also gives you the guide to a tool we have developed together with colleagues in Vienna, Professor Preinsack and her team, which is called Pluto, which allows you as an organization, as an institution, to assess the public value of your data and helps you then to take decisions along the lines of data solidarity. Now, of course, a lot of the discussion, and as you know, I come from Europe, around data has been around privacy and about the access of individuals to their data, the right to their data. And of course, we fully believe that this is absolutely critical. But we suggest with the concept of data solidarity to start from data use. What are the data used for? And if these data have a public value, then they will be judged in a different way. And for example, if companies produce data, health data, that are important for public health and have public value, then there is a responsibility to share them and not turn them into profit. If they do turn them into profit, there is a responsibility to tax. And I think these are the kind of things that we will be looking at. So if we start again from the conference, we see that on the one hand, in some cases, we've been able to overcome inequities through digital with remote care and things like that. But still, we have seen that a number of inequities have actually been increased by digital technologies. We see, as I've indicated, the very uneven power between public institutions and private companies in relation to data, because many of the business models of the big companies are based on data extraction. And some colleagues in political science even speak of data colonialism. And of course, you in India have some rules about how data can be shared with companies or research institutions abroad. Many countries do not have that. And so a concept of data solidarity has an international component. How do we do that at the global level? For example, with the World Health Organization. But it also has a data sovereignty component. How do we ensure that the data of our population are secure and safe and not misused? And so getting that balance right between the international solidarity for data and the data sovereignty and the solidarity that's been developed within the country is absolutely essential. And again, WHO has not yet issued guidelines on this, for example, and we are having discussions with the European Union because the European Union, with its various acts and regulations on data, and of course they are leading here, are very focused again on privacy, on individual data rights, and have not yet looked at this dimension of data solidarity enough. So basically we are saying that we cannot allow that data processors accrue profit at the cost of people and communities and at the cost of many countries of the global south. Because, you know, there is no legislation in many of the countries of the global south. They need digital infrastructures in order to serve their populations. And one can see that the regulatory governance situation is lagging behind. And therefore, the people who actually give all the data, and particularly now artificial intelligence lives off data. It's a data gobbling machine that there is no rights to those data and there is no concept of solidarity. So we are urging that we see clearly that individual control of data is not sufficient, that it needs to be complemented with data solidarity, and that we need to establish, particularly for public health goals, a solidarity-based data governance. And that shouldn't be in terms of concept, shouldn't be that difficult, because, you know, population health is based on values such as equity and solidarity. So we need to apply them to this enormous new development, and we need to strengthen the public, the collective control, and the ownership. And I think it would be very interesting to, as we've discussed with Anurag, to particularly discuss this in the context of India, because, you know, the larger the data pool is, we're talking of scaling up in this session, but that's the other side of things, that, you know, the big private companies want access to large populations. And as we discuss scaling up, we have to discuss that balance, the access to large numbers of populations, which of course is also an element that is so important in the rapid development of the digital, in quotes, in China, because it is access to very large populations where one can then develop policies and programs. So this public value of data, we believe, will improve that, will help improve the lives of people, and that's an important part, as you will see in the glossary, to protect from harm, because we always have these two sides, and the safety is an absolutely critical component as well. And one of the things we are also looking at is what happens to communities or individuals if they are actually harmed through this data extraction. Do they have any rights as individuals? Where do they go to if they are harmed through this? And you know that there have been some very negative examples how predatory data have been extracted and then abused politically, for example, in some African countries. And we can see that as more and more mis and disinformation enters the health sphere, something very similar can happen. And people will actually argue that their arguments are based on data, but there is no way in the end to really control it, to check it, because, you know, the people own the data and it's not available for access generally. So obviously my plea is that while we invest in digital infrastructure and scaling up, particularly in underserved areas, that we build governance systems that ensure this type of data solidarity, which we think will also increase trust, will increase transparency, and is of course a very significant part of the ethical use of data. So the ethics of this is also a field that must be developed more broadly. The other things, I think, you know, in terms of scaling up, you will all be discussing anyhow, like interoperability and all these issues that we know are critical for this area. But if the scaling up starts from the wrong premise and does not have, you know, an adequate governance and legal base, then we will enter into a very, very difficult situation. So yes, we need to scale up digital health in ecosystems. It's obviously not a luxury issue. It's an absolute necessity, and it will be the backbone of smarter healthcare. It will be the backbone of a public health that can then really assess the needs of populations and how successful public health interventions are. And we know we need this because public health interventions are complex interventions. And being able, for example, to be able to follow populations over longer periods of time is also something very critical. In pandemics, of course, it's about having real-time data, what's really happening where, and being able to see it. So increasingly we have the technology, we don't quite have the political will yet to really look at these issues seriously. We'll see, for example, it's not quite a health theme, but you will have read that the European Union is asking some of the big tech companies to actually pay because of not adhering to the European Union rules. So we'll see what comes out of that. But we also see, and that's a thought I'd like to leave you with because of this regional summit, that this is not only an issue of data, it's not only an issue of health and public health, it's also become a geopolitical issue. Because, I mean, some people say data is the new oil, it's not quite a correct comparison, but it does show how important data are and how much value they have. And therefore, what we do have to make sure is that we create the right element, not only to measure progress, but actually to really drive progress. And we can only drive progress through solidarity and through public value. Thank you very much.
Thank you very much, Ilona. For some of those who may know this entire World Health Summit, the reason it exists is because of part of her vision in bringing these contentious topics, as you said right towards the end, Ilona, geopolitical. These are geopolitical issues, and I think it's best to treat them as such. And remember that no answer to these things will come purely from, academic thinking about it, but recognizing there is value. Now, some of you would have heard recently about 23andMe going bankrupt. And there's tremendous worry because you don't know in whose hands that kind of genomic information would end up. It almost makes people worry that, genomic information is so dangerous it can't be shared with anyone. There is no perfect de-identification. At the same time, everybody who gets a genome sequenced or analyzed has a meaningless data in their hands if other people had not provided their genomes for any meaningful thing to be done. I think in this world there are some great examples that merit discussion. And to do that, one specific one, UK Biobank, I will trigger it off. But the person discussing it, let me tell you a little bit about her. Brahma, trained as a statistician, as she told me yesterday, was good enough with maths to have done theory, but chose to do applied, in which everybody thought, what's wrong with her. Eventually found her calling working with medicine and health problems, respecting multiple disciplines, and is actually on the leadership of the Yale School of Public Health. A lot of her work and election to the National Academy before the age of 50 comes from her wonderful work in statistical genomics. And she, who better than her to understand the power of genomic data when used well through appropriate channels that actually have all the principles that Ilona talked about. Who gets to access it, why they get to access it, how it is secured, how it is used. But I'm going to stop speaking here because the real expert is here. So Brahma, over to you.
Thank you so much, Anurag, and thank you, Ilona, for that beautiful and elegant introduction to the complexities around data. It's definitely a non-linear topic, but I always like to start with a story. So I have been a mathematical statistics major for a long, long time in India. And in my early career, in order to get tenure, I stuck to the technicalities and the theorems. And then suddenly, something happened, and I went to University of Michigan School of Public Health, and it changed me. And changed me to, I think I was a statistician. It made me a human. And as a process, sometimes you really need to place yourself in positions that are uncomfortable to you, where you grow the most. So I was leading the building of the Michigan Genomics Initiative, which is a 100,000 people cohort now at the University of Michigan, with genetic data linked to electronic health record, same as the UK Biobank. But I'm talking about this study first because I know how we collected data and I could actually interact with the patients and participants to ask them why are they giving us this data. So the core digital element of this biobank is electronic health records and genetics. But then the participants also consented to linking their data through their social security number, which is the Aadhaar equivalent, to any other forms of retrievable data. So we also have, through the electronic health record, over time, residential information through which we could actually map to geocoded residential location and neighborhood level variables and air pollution over time. We could also link to medical claims because electronic health record data often does not really give you an idea about medical claim. So at the end of the day, we had built this massive data ecosystem which has your EHR, which has your genetics, which has everything else that you could link with social security number. And you hear so much about public concern about confidentiality and privacy of data. So I was always wondering, why did these people give us the data? What better to have a patient and participant engagement studio, and we had a chance to talk, communicate with the participants. We collected data through an app, and I strongly encourage you to look at this app. This app is named My Data Helps. The Framingham Heart Study also collects data through this platform, which is a secure linkage of data, and you can consent not just to your electronic health record at one institution, but your vaccination record in a pharmacy. You can consent to various other sources of data that the participant owns, right? Ultimately, I own my data, and if I give the investigator permission to link all of this data, that's sort of my right. So when we ask the participants, because I always want to model as a statistician selection probabilities. Why did somebody choose to participate in a study? So we asked the participants, why did you give us all this data? This is incredible amount of data. You know what they said? This answer was completely unexpected. So most people said that somebody in their family had been cared for by Michigan medicine physicians, or somebody had gone to the university and that changed the economic and financial outcome of the family. They feel indebted to the University of Michigan researchers. They're not going to give this data to someone else. They trust us. So this trust with different communities, as you try to understand them, because data is sort of the way the population speaks. If you have to understand their language, you really have to understand the communities. And so, flash forward, I was in Arizona in reservations of Native Americans and studying heart health with a group in Colombia. And again, the same issue. Data sovereignty is a part of the tribal constitution. And they're much, much more advanced in terms of thinking about data than we are aware of. So communities actually have thought about data. How do you bring that socio-cultural context to data? This is a very important point. So Michigan Genomics Initiative taught me a lot about participant trust. And then recently we published a paper where we analyzed data from the UK Biobank, from Michigan Genomics Initiative, and the NIH, all of us. So UK Biobank has been really transformative. How many people in the audience have heard about the UK Biobank? Yes, so many of us. And the reason I think it has been extraordinary is because of the democratization of the data. Not really holding it for particular investigators that they are going to do a project and there is a claim and that project never gets done. Anybody in the world can go through appropriate procedure and get the data and work on a problem simultaneously. And different groups looking at a problem from different prisms is the whole robustness of statistics and of science. So UK Biobank, about 500,000 people with genetic data, electronic health record, survey data, imaging. Now they're also collecting environmental exposure data as measured through biomarkers.
This has been game changing for science. So as soon as that model was set up, and I don't think that if the UK Biobank was set up by 15 investigators and only be used by their teams, it would have been that successful. And so similarly, in the US started NIH All of Us with a really intentional mission to oversample underrepresented and historically excluded groups in science. So that brings us to how do we quantify who is underrepresented and unseen in our data sets? So genomics is a great example where everybody has to deposit their genomic data, so you can actually do an inventory of the number of human genomes over time, which ancestry they come from. And let me tell you certain numbers. So in 2022, there was a Nature Medicine paper which actually tabulated the representation in all of the human genomes that have been tabulated. 86% in 2022 come from European ancestry. Indian subpopulation, which is almost 20% of the world population, contributes less than 1% to the genomic data. What are the consequences of this? If you have that data and all the discoveries and all the gene-edited therapies and gene-guided information that's being discovered in a 86% population is being actually transferred to you. And maybe there is some value of it, but it is not being transferred in an optimal way had you had representative data more than 1% of what's represented in the biobanks. So can we, as statisticians, fix those problems? We have methods where we do transfer learning, right? This whole summit has been a real wonderful, intricate weaving of data and health and rights and methods and models and AI. This is beautiful. But can we fix that if we have 86% data and we have all the summary statistics for genetic polymorphisms from European population and use transfer learning to get the optimal risk score for South Asian ancestry? The answer is no. You need enough information of data. So my title at Yale School of Public Health is Senior Associate Dean for Public Health Data Science and Data Equity. And so I went to Yale because they were willing to put data equity as a part of my job title. I posted on LinkedIn 8 months ago that I'm the first person in the world with data equity as my job title. I obviously mined LinkedIn before posting that because I know that if it was true, then people will catch me. So now I think that equity has become a very polarized word in the current US environment, and I'm not get into that. But what does data equity really means? Data equity means that everybody, regardless of their personal belief or circumstances, should benefit equally from data science resources and innovations. And that means in terms of the availability of data and the quality of data. So we are very far from attaining that dream of data equity, but I do think that getting all of these different biobanks together with multimodal data, which does not codify an individual's existence in terms of just one domain, just genetics or EHR, looks into social determinants of health, looks into temporal life course measure of exposure, is really going to tell us more about individuals, and combined with the powerful data ingestion pipelines and tools that we have discovered, it is going to give us granular representation of human existence and human health, which is really, really complex. So when we analyze these data sets, I think we should really think about looking at a global landscape. So I want to tell you that there is an initiative called Global Biobank Meta-Analysis Initiative, which has now consolidated nearly 30 biobanks from all over the world with a better representation of South Asia, East Asia, Africa, Scandinavia, not just UK Biobank and NIH All of Us, to actually give researchers access to look at the world. And I think the onus is also on us to go and propose our projects on global data sets and also work on local data sets and see that what can we contribute. Where am I going with this? If you look at those 32 biobanks which have contributed data to Global Biobank Meta-Analysis Initiative, I want to see an Indian biobank, a Bharat biobank, where you have 2 million people represented from all over India with all its beautiful diversity and ancestry, with electronic health records, genetics data, and you don't have to release the biosamples, but I wish the world of scientists could actually write papers on the data from the Indian subcontinent. I do think that the discoveries will be phenomenal, not just for India, but for the whole world. So I do think we have lots of models, lots of tools, and during a lot of work during COVID, what I realized that I could build a model with 5 different compartments and lots of intricate parameters, but we just did not have data to afford those models. So unless we represent the population and invest in big integrated data sets, so this is sort of my dream that I want to see, just like UK Biobank, a Bharat Biobank being released to the world. So I just want to end on that note.
So now the platform is set up with dreams of solidarity of data across the world and a Bharat Biobank to contribute to larger initiatives. Let me move to Dr. Prabhakaran, who is probably the closest one amongst the people on this, well, eventually it might be Mona, but with the largest cohorts built in India, covering dense data types, for example, the PCARs, where I've been lucky enough to work with him. So Prabhakar, in maybe around 5 minutes or so, can you tell us how Indian efforts, which are still mostly individual investigators and consortia of investigators, are already scaling up the data ecosystems for effective decision making in areas like cardiac risk assessments and so on? And where do you think we should be going forward?
Thank you, Anurag, and thank you for those 2 presentations, which really sets the stage for discussing as to what we would do. Now, where is India in terms of data? I would think that we are at the foothills. We have to climb a mountain, but we are at the foothills. But we have navigated the contours of that foothills so that we know what lies ahead. And we also have some learnings from the other ecosystems, the UK Biobank, the Framingham study, and several others in the world. Now, in terms of the challenges, I mean, the opportunities are enormous, so I'm not going to talk about the opportunities. I just want to get back to around 25 years back when I was asked to give a talk as to what are the causes of cardiovascular disease in Indians. I started my talk with 7 blind men and the elephant. And as I was giving the talk, I realized that I was thinking like a clinician. What is required is a system level thinking. And that is where we need to think in, when we're looking at Indian data sets, we need to think in terms of a system level thinking so that we actually look at all the aspects that are needed to create that Indian ecosystem, or I mean, it should go beyond the Bharat Biobank, because when you're talking about the Bharat Biobank, we're talking about only the mechanisms of disease, the addressing the problem of health and other issues. But there are multiple things. If you have to actually complete the public health loop, as somebody said, you require to work from epidemiological, basic biochemistry, basic biomedical research, and then move on towards efficiency, towards efficacy, effectiveness, efficiency, availability, distribution, surveillance, and then link it to policy. So there are multiple things in the ecosystem. So in terms of one aspect that we are talking about is building these cohorts and building them in such a way that they're available to everybody in the ecosystem, not necessarily only the academics, the researchers, but it should be available to the policymakers, it should be available to the system in terms of how we use these data for improving the health of the Indian population. So I'm going to give the example of the PCARS cohort. It started off as actually a surveillance model, to create a model surveillance system to look at cardiovascular disease in India and South Asia. But as we did that, we realized that we have collected enormous amount of data in the first cross-sectional survey, because all cohorts start with a cross-sectional survey. I said we should repeat it every year, annually. So it's become a very rich cohort, and then now we have a program grant from NIH where we are looking at imaging studies. We have a brain grant which is looking at future prediction of Alzheimer's and dementia. And we have several other grants in the pipeline. So we have the lung disease, we have the liver disease, we have multiple other factors which we are looking at. But it's still one group, it's still one set of investigators. So we need, the first thing we need is to do a landscaping of all such efforts in India. That's number one, and I hope this particular dialogue will help us in setting up that landscape. The second thing, we attempted that landscaping and bringing together multiple cohorts in another big data-driven work that we are doing in terms of linking air pollution and environmental health to cardiovascular diseases across the lifespan, starting from the fetal life, the early life, onwards till the end of life. That is linking the womb to the tomb, as they say. And there we got 7 different cohorts put together, and then we used multiple mechanisms of data collection and large amounts of data set. I mean, it's really big data, because we do have data from the Environmental Health Ministry, the satellite data. So we use multiple levels of data. So that's one way of doing that. But going beyond, we are talking only about chronic diseases. But I think we need to look at a Venn diagram and fit that Venn diagram into our data collection. What are the 3 components of the Venn? One is the health data. The second is the environment, climate change, and all of those 3 things together. The third is the economic data. If we get all the 3 together, we can create a healthy population. And that's where we require to get all these data. Now, how do we link the data to the system? That is a big question that we need to pose. So there are many things starting from surveillance onwards, but I think when we are looking at data sets, we need to pay attention to culture sensitivity. It should be specific to our context, because what is applicable in a Western society may not be applicable to us, and we have learned that in a very bad way. We have, for years together, we have been treating our patients with hypertension beta blockers, and we now know that actually beta blockers accentuate the South Asian phenotype, which has got the highest risk in the world. So we need our own data sets. Third, I think whatever we do, we have to contain costs in terms of obtaining the data. Fourth, we have to have equity, which has been so elegantly presented. I won't talk about that equity. Fifth is, how do we obtain a scaled up model of this data that we are collecting? So we need to pay attention to scale. And last is how in a sustainable manner we are going to get this data, but how we are also going to build human resources and capacity to use that data. So there are several questions that we need to pose. And lastly, I want to leave with a quote. When I was a school student, I was very fond of reading, and I read this book by Alvin Toffler, which came around the 70s, a book called Future Shock. And I was really struck by one or two quotes which have actually become relevant. I won't give the second quote, which I can talk to you later, but the first quote which he said was, the most successful man of the 20th century, in those days there was nothing about women, gender issue. He said the most successful man of the 20th century would be one who learns, unlearns, and relearns. With regard to data, we read the same thing, because it is so dynamic, it keeps changing so fast. We should have the capacity to unlearn some of the things that we have learned and relearn new things. So I'll stop here.
Thank you very much, Prabhakar. And something I did wrong, because I'm so used to in health summits, everybody knowing Prabhakar and Prabhakar introducing me to them, and I forgot to mention to you that he's a cardiologist turned public health expert, the leader of Center for Chronic Disease Control, one of the key people who built up the Public Health Foundation of India, a dear friend, and of course one of the key people behind PCARS. So since you brought up climate, Prabhakar, so importantly, that it's not just about health data, or it is health data in a different sense of the word, Let me move to the only person amongst, not only, you also do quite a bit of work in it. But Madhusudan, you have cut across as ADB, not just countries, but types of data, collecting health data in different programs, climate change in different programs, environment. How do you see this new ecosystem, perhaps transnational, that looks at this wide variety of data and then shared to allow us all to use it in a better way? Over to you, your experiences primarily.
Thank you, sir. So a large part of my work has been in India. A large part of that work has been with primary healthcare, largely with rural communities, and a lot of interaction with the frontline workers. So the data angst, if I may put it that way, that gets expressed at the front line, and it cuts across programs. You know, it would be, you take a climate intervention, you take an NCD intervention, you take a RCH intervention, because on the ground there's only that ASHA reporting in all the programs, right? Or it's only that A&M. A lot of our work also has been in focusing, I mean, at least in ADB, has been on urban health. One of the things that we have started noticing is that there is a stagnation of the disaggregation of data in programs. So there are these specific categories that seem to persist, while the vulnerabilities, you know, they are stratified, but it doesn't get reflected in the data set. So you have standard rural, urban, men, women, others, you know, but the moment you just confine all of the information in these 4 or 5 categories, you miss out a lot of other, you know, geographic and social and economic and digital vulnerabilities that exist out there. And I think unless we start to think how are we going to capture that, we will not be able to address or tailor our programs, our response to programs to some of these vulnerabilities. So that's the first bit that I would like to indicate, that we need to start thinking of better disaggregation. When we started our NUHM work, we had information on rural and urban. We did not have information on urban poor. India right now has a lot of peri-urban areas. We don't have that disaggregation. We still go by rural and urban. So we need to start looking at how do we sort of dismantle the stagnation in the disaggregation that's happening around. The second bit is that there is a lot of excitement. I was also in a panel just before this where we were looking at a lot of platforms coming up, a lot of apps coming up. The most useful data sets or the most useful platforms for health providers have been those who have stayed available. I mean, there's been consistency in their availability. So if you have a NCD portal today and you have something other portal next time, it sort of builds on their ongoing work, because some of these never sort of go away. They're like registers, they are there, they are kept for, you never know when you might be required to go back and again enter in that register. You never know when you might be required to go back and enter data in that portal. So it's important that whatever data sets that platforms that we're creating, there should be some consistency in their deployment so that there is utility of it is maintained. Otherwise, it's easy for us to come up with something new, fire and forget, but it's not that easy when it comes down to a health worker, an ASH or an A&M. So that's the second bit. Third is that we are not evaluating as frequently as we should the digital interventions that's happening. We still go and evaluate a lot of programs in India, outside of India, but and I'm not sure if we have enough, if we are clear on the framework that we should use while looking at some of these digital interventions vis-a-vis public health programs. So I think that's one area that I believe we should have some focus on. Last 2 bits, data policing is now, maybe it's not as frequent, but it still exists. Whether data is enabling the provider, whether data is enabling the user, or is it still being used as, as a mechanism to misplace accountabilities, as a mechanism to, indicate other things. So it's important that how do data there's the honesty, the trust bit that, Dr. Brahmer indicated, that how do we build that trust of people to give that data, and how do we build that trust in the health systems to say that, yes, this is reflecting my reality, or this is reflecting the reality of the program or of the, whatever implementation things are happening. So that's one bit. And lastly, we have always felt that there is over-reliance of a lot of ministries on partners for capacities on data, and unless these get institutionalized, unless there are cadres of specialists who are within the ministries, who understand the context of the program and support them from the inside. And I do recall that there was a session that do we need a course on digital health. I think it was one of the sessions that Ashoka was conducting, and I think it's really, really important, because while we are talking of public health cadre in several sort of areas, but I don't think that's still being talked enough for the digital health, and it would be very, very crucial for us to have that human resources embedded of the government, which has a clear career pathway and incentives, and so that the reliance on outside mechanisms has to reduce for the governments. So those 5 small points. Thank you.
Thank you so much, and that leads me perfectly, because you said you need the right people. You can't just do consultants being called in by the government as partners all the time. There needs to be a proper institutionalized system with the right trained people for the job, doing it on a long-term basis, because data changes. And that's the only way one can generate these data systems for decision making. So Mona, you are now the incoming director of the new National Institute for Digital Health Research of ICMR. I am very sure amongst various things you will be interested with will be the idea of institutionalizing finally this area of health data ecosystems for health research, at least for health research. How are you thinking about this problem?
Thank you, Anurag. I have been listening very intently to all the panelists, and I think out of many of us, including Karthik, Brahmer, me, we've all worked in the US and looked at the VA very closely. So coming back to where I was thinking, and I think Dr. Prabhakaran also mentioned, there are few things as I have made this journey on the past 20 years. And coming from a community medicine background, and more as I think about it, I went from community medicine to US, joined the medical informatics, did epidemiology, came back, joined back in community medicine, went into the rural health system. Then was kind of, because the only position that was there at PGI was in ophthalmology, going to a clinical system. Two things that came out to my mind, and I had that discussion when I was thinking over, and I think when clinicians adopt public health, it is a much better option. So instead, I think we now have to take this now, like within the clinical systems, if population sciences becomes like a specialized course, it was actually going to make a huge difference. Because when I entered ophthalmology, I was the only public health system, and the only thing that was expected of me at that point was, we have the data, can you analyze it? I said, no. And that's, I've been the PI on my grants, and I think about population sciences. But it was very difficult for me to kind of make them understand what population sciences is, what is community health. And maybe when I left, I think they probably got the understanding. But at that point, I did start that thing, but it is a slow process. And Dr. Prabhakaran, again, he is a cardiologist, and he has taken up public health, so he has done wonderfully well. So having 2 cardiologists in my own family, I think I've realized that if we can get people within the clinical systems who are interested in population sciences, or if the community medicine, they kind of like, or the public health systems, after a year they go into a clinical department, take it up as a specialty, I think that is where that intersection is going to start. So that is one area which I thought maybe the capacity building can start in the medical colleges, because this has to be institutionalized. And Brahma, I think you probably don't know it, but
worked closely with Brahmaji, so he has highly talked about you. This was another cardiologist. So the entire cardiology and ophthalmology has been at the intersection when I talked about it. Second, then I headed the ethics. Like I was a convener for ethics, intramural ethics at PGI, and I chair the ethics at IIIT Delhi. There's a huge difference how engineers think and how medical people think. There are no data scientists in our ethics committee. There's nothing called medical informatics. How you share the data, the only thing, there's an Excel sheet, and if you say, okay, you de-identified the data, they will take it out. That is the thing. And if you push them, they will send it on an email. So, having said all this, because we come from this perspective, these are things which probably now need to be taken up seriously. With so much of this going on in the ecosystem, it's high time we actually set these things right at the undergraduate level. We need to start teaching data science, something at the undergrad level. It has to be a course at the postgrad level, and this has to be a competency when they come out. Unless until it is done, institutionalized in the medical colleges, where our training is done, that has to be there. And in the same tone, I will ask the engineering side, when they are institutionalizing this, for them, I think they need to understand the sensitivity of the health data. It's not black and white. There's a lot of behavioral data, a lot of those things go in when we collect data and the decisions are being made. So those things have to be kind of now started to cross-talk, but at both sides, we need to have data scientists in the medical systems, having health informatics or medical informatics and ethics departments. I think Dr. Joy Menon is here at CNC Vellore, who is leading the biomedical ethics, biomedical informatics department. That has to come up across India as we had it when we were trained in the US. The third, I think, I'll come to Elena. She talked about data solidarity. I think the HMSC, the Health Ministry Screening Committee, at this point, I think we are regulating pretty much the bio samples. They still allow us at least 10% exchange internationally for the quality checks. But we have a lot of those NIH grants and the other grants where we do share data across. So those kind of systems are in place, but they probably need to be updated and seen how we can actually have the cross exchange. The only problem that I've seen when we have on these international grants is the capacity building. So ultimately it is the data colonialism that has come up as an issue now that needs to be looked at. When we are sharing data, we need to build the internal capacities that we should be able to analyze the data equally well as internationally. If those capacities can be built as a part of the international grants, we have no problem sharing the data provided you give us the same capacity in the long run so that we are not always dependent internationally. So those are a few things that I think we really need to think very deeply. So with that, Anurag.
Thanks, Mona. So we move to a person who can take it forward into the decision-making side. So far we've been focused very much on getting the data. Even if doctors were trained to some degree in data science, even if we institutionalize everything, we realize that people who are neither sometimes, definitely not doctors, so Sandeep is in no way anybody would call him doctor in terms of medical. Of course, all of us are doctors on the PhD side, but many people would not think of him as an engineer, computer science person either. Yet for decisions to be made from typically cross-sectional data looking forward, you almost have to be inferring this does that. I change this, this will occur. It's a hard problem. It's not a simple problem at all, actually. There are so many things have cross correlations and so on that somebody could say that, eat more ice cream and summer will come. And it doesn't quite work that way. So we have a Center for Data Science and Decision Making at Ashoka, which is headed by Sandeep, whose background runs across a multiplicity of things. But Sandeep, what I want to hear from you is people who are not necessarily engineers or doctors. In this entire area of scaling health data ecosystems for effective decision making, where do you see the second part being trained, taught? Who are the people who can do it, and what are the challenges? You did for the pandemic.
Yeah, thank you, Anurag. So yeah, I am an applied mathematician. I guess what Bharmar was, I continue to be. So I'm not a human being yet. And may never be, actually. But, so for me, and just to illustrate your point, so we got into all of this health modeling through COVID, like a lot of people who do applied mathematics did. And we were involved, first of all, in this Sero survey that happened in Mumbai. This is just to illustrate how important data is. So it's a massive effort to conduct such Sero surveys. We are not at all equipped for these things, but we had team members. And when the data finally came, this was an era, this was July, June, and there was 3% Sero survey positivity in, I guess, in maybe Denmark, Sweden, I think. And in Spain, it was about 6%, where we had seen so much mortality. And suddenly in India, in slums, you see 58%, 57% positivity show up. So I remember, this was like my first kind of experience of actual discovery, learning the truth. But what was fascinating about that observation was, up till that time, all of Mumbai, BMC were focused on slums. They were completely, you put one more camp in Dharavi, you see what's going on. Everyone who comes visits Dharavi. But that data provided new insight to us. It told us that, disease has actually gone through slums already. It's much more other places that they have to worry about. So data makes all the difference in how we think. Very starkly it comes through. Because, slums are enormously crowded, and you put all kinds of restrictions on them. You cause so much hardship. So this was so important that we saw this, and the data kind of brought this to us. But then, the other experience for me in COVID was also that you had people saying, okay, it's going to end in 21 days, or it's going to end in 49 days. And that comes to your point that, one has to see all of this mathematical modeling with a great deal of skepticism. You have to be aware of what the underlying assumptions are they correct or not? So going forward, as we make effective decision making, education is extremely important. In statistics, we are living in a world right now, it's terrifying, it's exciting. Every few weeks you see new developments happening in AI. I don't know where we are going to be in a few years' time. There's so much changing, it's very hard to keep in touch. In that world, we have to learn a great deal, we have to learn to interpret data correctly, and we have to maintain skepticism. Now, in terms of decision making, I think the point which again came home to me was we were trying to get data, and the data tends to be very noisy. There are all kinds of human errors in it. Data from one area does not talk to the data from the other area. It's incompatible. There are human errors. There are language issues. So all of that makes analysis much, much harder. It makes decision making that much harder. We have nice techniques. We have robustness techniques. Variety of people looking at the same data is very healthy, because then through the mistakes, you figure out what's actually correct. But there are mathematical ways of doing robustness. There are mathematical ways of kind of correcting for outliers. There are mathematical ways of understanding that there are biases in the data. So we are collecting data from urban centers, but that's very different from the data that would be from rural centers, where it's very hard to get data, right? How do you collect the real data there? So all those bias needs to be appreciated. They need to be corrected. And you have to understand that you've not really corrected them with the kind of techniques that we have sometimes. So you need to have a much more sophisticated understanding. So I'll just end with that. I just want to, the broader point simply is that as we develop, as we evolve in AI and all these other areas, we need to develop strong technical, statistical, mathematical skills to interpret data carefully to help us make adequate decision making. I think that's going to be very important.
Thank you so much. And with that, I come to the last panelist. Dr. Karthik Adapa wears multiple hats, and sometimes in a panel discussion, not sure which is the most relevant one. Today, I'm not sure at all. So Karthik, you decide what you want to talk about.
Wonderful. Thank you, Anurag. I'll probably be the most boring one because I'm going to talk of fundamentals. I'm the regional advisor for digital health in the World Health Organization. And Brahma talked about the Bharat Biobank. Dr. Prabhakaran talked about India essentially being in the foothills, and Mona talked about the institute that she's trying to set up. And we also had Professor Juneja talk about decision making. Now, what we do at WHO is essentially, as a member state driven organization, we essentially help countries and our member states build those foundations. Essentially, if there is a UK biobank, if India wants to build this, India would need its digital health systems, which are based on standards and interoperability. Now, that's by far the fundamental foundation, and that's where WHO comes in with standards like the ICD-11, for instance. Now, nothing that Brahmer can work or a mathematician can work without standards. So, and standards are not something which are extremely glamorous, right? Now, the very fact that you have so many standards in healthcare, you have a standard for laboratory, which is LOINC, you have for clinical language, you have SNOMED CT, you have something like ICD-11 for diagnosis. Just the fact that healthcare is a very complex space with almost 40 different standard development organizations, and each one having multiple standards. So today, you have a landscape of about 100 odd digital health and data standards. So what countries, as they build digital systems, the kind of difficulty is how do you have them on standards and interoperable digital systems? And therefore, especially in LMIC countries, the key thing is how do we enable, how do we build capacity building on these standards? Now, I just want to kind of talk about one basic standard, which is FHIR, which as a transport standard. Now, the very fact that you have FHIR, which gets implemented in the US, is very different from the way FHIR gets implemented in India. Now, as an open standard, therefore, the capacities that you need to build within each country, and that's where WHO comes in terms of ensuring that we have our workforce, which is locally trained so that you can build this sustainable digital health transformation that we're promoting in different countries, and for that, we will need open standards. The other piece that we are essentially trying to encourage member states is on what is called a full stack development, which is open source standards, open source architectures, open content. Now, in this full stack approach, essentially member states very often have a preference to use commercial proprietary solutions rather than using open source standards-based solutions. And therefore, this movement towards using open source technologies and open source standards is again going to be a very difficult one, because when you look into the DPG registry, you just have about 195 open source tools, whether it is on the AI side or on the digital health side. While we know that countries have essentially built thousands of applications which are there in both in healthcare and non-healthcare. So the challenge is how do we then move countries towards building these and using these open source standards and open source technologies. Now, and therefore as WHO, we essentially need to do the walk the talk as well. And that is where I want to kind of highlight a new initiative that we have, which is again an open source standards-based initiative called the Global Digital Health Certification Network. Now, essentially building on COVID, there are 80 countries in the world which have come together, and WHO essentially uses a trusted architecture approach. What happens is country A, through a trusted key, provides this access to their data to WHO, and WHO does not have access to the data, uses a trusted architecture approach, but using this open key transfers this to country B. And then country B gives it to countries, and for country B, there is access to country C. Essentially creating an entire network, and this is the Global Digital Health Certification Network, which got into practice during the Hajj pilgrimage last year. And therefore, now when you have citizens traveling from country A to Saudi, using this trusted architecture, physicians in Saudi Arabia can access the digital health records of the patient in a credentialized system from the home country. So using this trusted architecture approach, WHO is essentially able to provide access to patient records from multiple countries. And now this is a new approach that is essentially coming in, and there's efforts to bring in more countries into that. So I just want to kind of highlight the fact that as countries build open source standards-based digital health systems, that is when we will be able to build a large database like the US Biobank and certainly what Dr. Prabhakar and others have built in. So I want to just highlight the most boring part, but the most foundations that are needed for scaling digital health systems. Over to you, Anurag. Thank you.
Thank you so much. Karthik is a medical doctor, a bureaucrat and IAS officer. He is also studied academics in artificial intelligence in America. And of course, he does all these things together in his current role. So with this, and the beep come just in time. So we will open this. We're a powerhouse of an audience. Let's go to the audience. Let's start here first.
Thank you. I'm Dr. Giridhar. I'm a community physician, a medical doctor. Went on to do my PhD in infectious disease under Dr. Anand Krishnan. Served with the WHO for some time, served with the JPIGO. I had some opportunity to speak with Dr. Prabhakar and Professor Juneja earlier. Also with Brahmar over Twitter earlier. But the kind of fundamental question I'm just trying to understand here is, while we speak about data scalability and taking data and comparing it across different geographies, I think there is a data inequality the way the data is getting collected in terms of the processes, the case definitions, the way that people collate the data systems. It could be the COBO tool, it could be the ODKs, it could be the different HMI systems. What kind of approaches have been considered in that space? Because that's pretty critical. What Dr. Karthik had mentioned is something more with regards to, okay, we set up standards so that data sharing happens. But in terms of the data processes that is going to lead, because that inequality is still there. And at the end of the day, if you're speaking about data solidarity, data equity, unless we're not going to address that inequality in the data collection methods, it's not going to happen. So any thoughts on that? Thank you.
Hi, I'm Mayuk and I work with the Koita Center for Detailed Health on data compute infrastructure. So while we talk a broad topic here was about scaling health data in terms of both the breadth that it covers and also equity in the people that it represents. I think one major point of discussion that people don't touch enough about is equitable access to data compute as well, because the larger your data sets get, the more complex they get, compute also scales up. And this is a problem that we see everywhere. So at universities, projects like these compete with other departments that also have very data-intensive compute. Even on a national or global scale, institutes that have different research budgets or administrative budgets compete, right? They might not have enough adequate data to even pursue their research projects. And it's not just about funding, right? It's also about the very cost of compute itself, because while cloud providers have made it more equitable, but there's also the problem of emerging trends, for example, generative AI pushing the cost of components, right? Because of that, GPUs become costlier. It's much more difficult for even researchers to procure the right kind of compute that they need to do the infrastructure. So while we are working on data equity, where are we on compute equity? In fact, it's not just about hardware. I think there is not even enough dissemination of knowledge on how to effectively use the compute that you have, because often with large data, people often fail to utilize the processors and the graphics cards that they have already to run their modeling. So yeah, so where are we on yeah, so where are we on enabling equity in data compute for all the research problems on data that we have? Sorry.
Good morning. My name is Sakshi Rastogi. I'm the co-founder of Helium Camps. We're a preventive screenings organization, and our strength is to go to communities and screen for 30 to 2,000 people in a single day. Needless to say, we are creating and generating a lot of grassroots data for health. My question is are there any guidelines or any open source platforms where we can build better systems to understand how many more parameters of health data can we include as part of our screenings? Because we're already going on ground, and I've learned a lot from this panel in terms of what could be potentially incorporated. But are there platforms where we can look up how much more and what all other parameters can be included in our initiative, so that it can generate good insights for institutes like the ICMR, Ashoka University, or further, if you want to create a strong data set, what would be your advice in terms of?
Hi everyone, I am Vishal. I am from the ICMR National Institute of Digital Health Research, and it was a very interesting discussion. All the important aspects of data has been discussed. Especially listening to Brahmar has always been a pleasure. I mean, in the last keynote address you gave at IISA, you also talked about data quality and the wonderful you and your team is doing wonderful work on how to identify as well as address data biases. So that was a very important aspect which Sandeep also talked about, and I think that has to be enhanced. I think statisticians have to do a lot of work in those aspects. Coming to the question, to the open panel, European health data space is coming up, and they are built on the idea of federated data sharing, which I think Dr. Karthik also talked about. Trusted architecture approach, I think it's similar to that. So do you think this can be taken up as a good use case? Obviously it will be difficult, but for other countries as well. Thank you.
A simple question. Myself, Gerald Napoleon. Last 25 years, I am doing digitalizing health records for hospitals. More than 5 crores of patient medical records I digitalized last 25 years. I am facing one problem. All these data analytics we are doing for diagnosing, the treatment happening inside the hospital sometimes causes the reason for death. The miscommunications. Before creating all these artificial intelligence decision-making systems, why we can't think about creating a proper digital environment for taking proper decisions and executing the decisions inside the hospital? That's a part of this discussion should be.
Yeah. So, with me? Yeah, okay. I just wanted to make a few general comments, and I'll take one minute. I think somebody was saying that they're doing 32,000 screenings. Actually, in this country, you have a lot of cross-sectional data. In fact, we're looking at equity and we're looking at cardiovascular risk factors in women. We have put together a data of 1.7 million people. So that's the amount of data that we have. But what is important is, why is US way ahead or UK way ahead? Because they established cohorts. Now we have an opportunity. We have established the PCARS cohort, which you're talking about. It's 4 times the Framingham study. 20,000 people with almost 80% follow-up, 3 follow-ups with deep phenotyping of these individuals. So we should try and collect those kinds of data from the country. The second is, we also have enormous number of hospitals, and we have to try and harness hospital-based data. Coming to your question, I think that's where decision support systems matter. And we are working on the electronic decision support system, which is part of national policy. In fact, the Ayushman Bharat Digital Health Mission has taken up our decision support so that errors of omission, errors of commission are taken care of. It's been developed for cardiovascular disease, chronic obstructive lung disease, and we are working on antenatal care, but there are several others which we can do. So once you have this electronic decision support, you can actually take care of most of the problems that you're talking about.
So 2 that I can possibly take up. One, Mayuk, you asked regarding compute availability. So under the India AI mission by the Ministry of IT, they are selectively through competition for people who are deemed to have ideas worth pursuing by any mechanism whatsoever, it's imperfect, are given access to GPU and other accesses at a very, very heavily discounted rates or even free of cost, depending on who it is. But yes, that is not solved necessarily an entire country's problem of academia, and even industry runs short at times, but then again, it's a different issue altogether. But the idea that people will need access to data storage and compute on the cloud at discounted rates before the data ecosystems make any dent at a larger scale is very much recognized. I'll also take up one very quick thing regarding data collection. There are two different dimensions in this world in which we look at it, right? I mean, you plan everything out a priori for well-done studies, and that you at best can trust researchers and create platforms for those data to get shared and used. Other is you simply capture all data that is occurring accurately and scale it to very, very high levels and use it to make judgments. And I think, Brahma, what you talked about at Michigan probably addresses how you guys did that. Any comment you want to make on that?
Yes, I think that we could start another hour-long panel discussing the questions, but in the interest of time and also hunger, I just want to emphasize on a few things. I think this, I think it's related to your question as well, that how much is enough and how much, what is the N and the P, and what kind of variables do we collect which are correlated and redundant. So I think that there are two kinds of data collection. So the cohort-based data collection, which is much more focused on a particular disease type and population and studied over time. But the agnostic one has become very popular, right? This biobank approach that we are collecting as much dimension because we do not know what is going on. And so we have now, if we collect large number of variables on a large number of people, we will discover the unknown and using the proper tools. So I think that that's becoming very promising. And I think it's very unrealistic to assume that you are going to have a copy of your data, everybody going to have a local copy of the data on their desktop. So it is becoming very common that the cloud and computing system is going to set up, like the NIH all of us did, which I thought was really revolutionary, that you did not need an institutional affiliation, you did not need an IRB. If you had a valid US ID, you could get a computing credit in the web, in the cloud services for $300 compute dollars, and with that you can start your initial exploration of the data. And for students and other, for people who do not have access to computing resources, there is huge subsidies. This is how things should be set up, because an individual institution or a PI does not have the resources like UK Biobank or NIH, all of us, to invest in an army of people who are making the data secure and interoperable and linked. And then I want to come to the point of heterogeneity and harmonization, as different hospitals use the same code differently. For the same disease, certain codes are used more frequently in one hospital as opposed to other. These are coding system heterogeneity. So after doing the ontology-based harmonization, you can actually use statistical methods to do the data-driven harmonization of phenotypes. And I do think that the more imperfect data is, the more statisticians you need to hire, because we actually know. I think statisticians and yes, as statisticians and epidemiologists are very uniquely trained to think about data imperfections. And I would say that with confidence, because measurement error, misclassification, harmonization, heterogeneity, meta-analysis, computer science students are not taught that. They think about more prediction. Y given X, taking data as phase values. Think about representativeness, generalizability, causality. These are our bread and butter in public health and population health. And I'd really like to make a case for that as we get into this agnostic era of large data sets and querying data set. Never forget the fundamental principles as we get jazzed by AI tools.
Fantastic. Anything from you, Karthik? All right, I think we'll end with Ilona concluding the session.
Well, I was going to answer the question around the European Union, but in a way it's also a bit of a reflection, because it shows that obviously different parts of the world approach the whole data issue with a different set of values, ethics, and approaches. And of course, the EU activities are very much driven by a European way of thinking. Let me just be very simplistic about that. One of the problems, if I were to identify it, but that's also an issue then for the various parts of the world, is Europe puts in the center the fact that data belongs to the individual. And that's it, you know, that's the basic principle. And the principles then that go through the Act, of course, relate to all of that: privacy, citizens' rights, a whole issue of around ethical data sharing, and also data sovereignty. And if you compare that basis, those principles, to the other two big systems, India is often not included in that list of systems. People usually compare the EU, China, and the United States. And I personally think it's time to include India into that list. But if you take that, you know, people would say Europe starts out from trust and control, that the United States obviously takes market-driven freedom with, you know, all the issues around their constitution and everything. And then in China, you have a state-first sovereignty. And so you sort of have to see which elements of, you know, different approaches then actually relate to what you're hoping to achieve, and to what extent that relates, in case of our panel, to public health thinking. You know, what are the values, and where do we not only look at individuals, because health is not just individual, where do we actually have to look at solidarity? And how do each of these 3 plus India 4 systems actually respond to solidarity? And the other thing I might say about the European approach is, of course, that by now it's a whole set of laws and acts. There is a sort of infrastructure already, all of it built on, you know, those principles, and they interact with each other. And of course, at the same time, and this will be a last central point, is that all of these acts try to make sure that countries are economically competitive in the data space. And for Europe, it also means trying to ensure that there is more innovation in the data space in Europe, because it's been lagging behind. And so in a strange way, you know, some of the innovation is not sufficient in Europe, whereas the legislation, typical European, is, you know, very, very far advanced. And there is the constant discussion, of course, in what way the regulation hinders innovation, or whether introducing ethical principles to innovation actually makes innovation stronger. And I think, you know, discussing more about that conflict and tension is something that all of the issues that we are considering needs to consider, and can perhaps be linked to many of the points that were made at this panel. Thank you, Anurag.
Thank you, Anna. Brilliant summing up. And with that, I can't do any better than to thank everyone, the audience as well as the panelists and the chair. Thank you.
Fortification of staple foods is considered one of the affects several factors, including good health, education, water, sanitation, hygiene, and women's empowerment. Women and children in the global south face the consequences of poor nutrition. Without targeted and effective interventions, sustainable development goals and global nutrition targets will remain out of reach. Fortification of staple foods is considered one of the most cost-effective strategies for addressing micronutrient malnutrition.
India has had a great track record on large-scale food fortification going back to 1950s, and we have a lot to offer for the people around the world. We thought of having a delegation coming through where we can figure out a way of partnering and collaborating together.
I expect to learn from India's vast experience in food fortification while I share experiences or best practices from Ghana. Nutrition is truly, multi-sectoral work. We can also see that in the participants who are representing their countries here. So we have health, agriculture, social protection, industry. Really looking forward to interesting discussions with the Indian partners from these different sectors, but also among the participants themselves.
Nos attentes en arrivant ici, c'est la consolidation du partenariat stratégique autour de la fortification alimentaire. C'est également comment nous pouvons lier ce que nous faisons au niveau de l'Afrique de l'Ouest avec l'état de l'Inde, puisque nous sommes en Inde aujourd'hui, qui comporte une telle forte population par rapport à ces indicateurs démographiques. Donc nos attentes sont énormes en ce qui concerne la région de la CEDEAO.
So this South-South experience exchange allows us to share our best practices and experience.
We think that this kind of exchange utmost importance because we have 5 years left to actually reach the SDGs until 2030.
We cover all the links on the value chain of fortification, and the most important is multi-sectorality, that all the stakeholders have its place.
We had one-to-one discussions with key partners from government, private sector, research and development, and it was very different from how regional exchanges or exchanges, learning exchanges of this sort are typically organized.
Très bien de savoir pour la disponibilité du prémix et le système de contrôle de la production jusqu'à la consommation.
J'aimerais que mon pays, le Sénégal, puisse prendre exemple le gouvernement indien juste pour les stratégies de fortification.
So we did also visit some schools that are using fortified rice for various staples here in India. And Catholic Relief Services, one of our major programming area is in school feeding. And we are also involved in the procurement of locally fortified food commodities. And potentially rice is very promising as one of the major staples also now in most African countries. So it will be good as a practical next step to see how we can establish some centers of excellence similar to some of the innovation hubs that we have here in India.
And I'm really hoping that we can take this further and continue exchanges like this in the future, but also building on the partnerships that were created here during this visit.
I'm really proud that the delegation is going to return to their home countries with all the knowledge, all the experience, and I'm really hopeful that the funders have also received a lot of feedback from this exercise on how exactly their strategy might look like going forward.
Food fortification is not just a nutrition intervention, but a social justice imperative. I therefore believe that if we must fortify foods, we must do it well.
access to proper nutrition is critical to move us towards realizing the Sustainable Development Goals. Nutrition affects several factors, including
India has had a great track record on large-scale food, and we have a lot to offer for the people around the world. We thought of having a delegation coming through where we can figure out a way of partnering and collaborating together.
Très bien de savoir pour la disponibilité du prémix et le système de contrôle de la production jusqu'à la consommation.
J'aimerais que mon pays, le Sénégal, puisse prendre exemple le gouvernement indien juste pour les stratégies de fortification.
So we did also visit some schools that are using fortified rice for various staples here in India. And Catholic Relief Services, one of our major programming area is in school feeding. And we are also involved in the procurement of locally fortified food commodities. And potentially rice is very promising as one of the major staples also now in most African countries. So it will be good as a practical next step to see how we can establish some centers of
sector as well. So really looking forward to that broad variety of insights from everyone. So without further ado, I would like to start inviting my panelists to the dais. To start with, if I may invite Dr. Varsha Tanu, who is an associate professor at IIHMR University. Please have a round of applause for Dr. Varsha Tanu. She is an associate professor at the University experience across the social development sector, and she's also done a lot of work in the academic and research ecosystem. Graduate from Delhi School of Economics, she brings multidisciplinary expertise in health, nutrition, water resource management, gender, comprehensive national nutrition surveys, micronutrient studies in children, and rice fortification across aspirational districts, not just in India, and through GAIN's other offices outside of India perhaps as well. So welcome, Dr. Supreet. Then I'd like to invite Ms. Neha Khara, who is the project manager for GIZ Senu project in India. Please welcome Neha as well. Is a powerhouse of expertise, and when I say powerhouse, you would see when she speaks, she really is a powerhouse of expertise and passion in the nutrition space, bringing over 17 years of very rich experience in public health and nutrition. She's a true advocate for meaningful and sustainable change, and now in the nutrition space, we need those kinds of advocates more than any time previously. And with the recent Nutrition for Growth Summit, I think we need more advocacy of nutrition as well. And then, if I may welcome Ruchika Chug Sachdeva, who leads the nutrition at the Gates Foundation. Please welcome Ruchika with a round of applause. She's also another hugely passionate person about spreading word about nutrition. She is ex-Path, and a lot of my nutrition team speak incredibly highly of her contribution in setting the ground for the nutrition work at Path. Now at the Gates Foundation, on the other side of the table, she's helping the foundation set their strategy and also helping the other organizations roll out their strategy in a very meaningful way so that the nutrition goals of the world could be achieved. So she has many, many years of work experience working in local and international NGOs and also in private sector. So looking forward to hearing you speak as well, Ruchika. And then without leaving my colleague out, Dr. Danny Shaji, who is the technical lead for the fortification and nutrition project from PATH, and essentially my right, left hand and feet and everything, because he's the one who knows more about nutrition than I do. So I'll be throwing a lot of questions at all of you. So Danny has a lot of experience of working in this space, being a food technologist. Any technical questions that you have on the supply chain, so please welcome Danny as well. Okay, so I was told this morning that Dr. Varsha, you have some slides to show as well, so I might give you the first chance if you want to come to the podium and we put the slideshow running, so we hear your comments first and then we get into the panel discussion. Is that good? Please come to the, yeah, come here.
Esteemed dais and dignitaries sitting here in this hall, and though it is like little difficult for me to start my introduction in the field from among all the nutritionists, little nervous, but yeah, so whatever, as it is said, that public health or nutrition intervention doesn't require much expertise. It just requires understanding of the community. That if you're if you understand your community, if you understand their needs, if you're able to build trust, they listen to you. And once they listen to you, then definitely having knowledge is something different, but behavior or having corresponding behavior change or translating the knowledge into practice is also very, very important. I think you all esteemed dignitaries and experts from nutrition field, you will agree to this thing, that without behavior change, results and outcomes are not possible. So similar intervention, though I'm not from academically, as you just heard that I'm masters, and I did my research from Delhi School of Economics, but then by training, yes, I have always appreciated the resource, and the journey started with having my MPhil with banana plantation, the local food resources, and which is in the both side of River Ganga, and how it nourishes the population as food security, and not as a food security separately, but nutrition security too. So, that with that understanding, and I just happened to go to a remote tribal area. Those who have traveled to Udaipur must be knowing Kotra, Jarol, Falasia, very remote, and absolutely after 5 o'clock, it's not possible to roam around freely in those areas, because they have the indigenous kind of liquor, and it's little people avoid going to those areas after once it gets dark. And in that kind of remote setting, when I travel deep down, because I'm I have a affection, I have a kind of love for passion for forest and this kind of natural setting. So saw two things, fruits and vegetables, nutritious things. Did not see even a single vegetable wala or vegetable person or vegetable seller during my route, but I saw small kind of shops after few short distances, and every shop would have local branded chips and cold drinks. So those things are, so even the grandmother is having chips, and the baby is also having chips. And they basically took the chips, they opened the packet with pride that they are having with, that's a symbol of increasing their income, and they are basically, imitating the urban, or they have adopted to the urban food, practice. So just thought of, and then villagers asked the villagers that why nutrition is at the last this thing. I mean, nobody talks about nutrition and other things, deficiencies, because as I said, after coming to IHMR, started my intervention research in those areas, and spoke to the women during FGDs, and I'll show the photographs, and they said they complained that earlier, when they were young, so they used to have crops which were included in micro millets family, and they have some local wonderful micro millets, kodra, hama, samalai, and those kind of things, which grows indigenously without any support or without any care. And even the foxtail millet, which we eat in fast and it's nutritious. But after certain time, when the new generation daughter-in-laws came, they basically don't want to do so much of they want that mixie or something to dehusk the thing. So entire processing is difficult, soaking and then processing it. So we just thought of promoting them for micro millets consumption again. And then micro millet consumption and promoting them, meeting them and saying that, look, those products, those chapatis and those, if you every day include in your food, it will going to improve your health. Because baseline was disheartening. Baseline survey, we basically in 3 blocks we conducted, and we found that, iron was beyond our imagination. It was 5, 6, and again the women, we found many pregnant women, and it was nowhere mentioned in NFHS data 5 even, and immediately after that we conducted that micro level survey, and then met the administration, and then started with building a connection with the community. I think now you see the global hunger index. You all know that we have a very low footing. And why millets? Because nutritionally rich, iron, zinc, calcium, micronutrients and other things, high in dietary fibers, low in glycemic index, even to obesity and those kind of problems, so even good for diabetes. And grows organically. That's the best thing which motivated me. Nutritious and grows organically, which motivated me. And hardy crops, so climate resilient, and you're ready to go with even 2 or 3 spell of monsoon, whatever that area gets, without any irrigation or without any fertilization or not even manuring. So even that works. So this kind of landscape is basically the typical natural landscape which you can see. So these are few because on sample basis, few farmers have started growing, and this kind of they exhibited batti, mal, hamlai, and those kind of local. But all these come under micro millet family, and but then with time, millet consumption has gone down to rural areas by 82% in Rajasthan and 77% in urban areas. Urban people have still adopted to few cookies and things like that of millet. But in rural areas now, they think that it is beyond their dignity to have these crops. So these are remotely located, and we are carrying out our intervention in these 3 blocks. So with episodes of many rounds of meeting with the community, because it's important. If you first thing is important that you build trust, and they should basically trust you that you are their friends. Otherwise, definitely like any other enclosed community, they don't like outsider to come and tell them about the. So we were now mostly those women are my friends, so they accept. Yeah. So this kind of meetings and encourage them to show their produces and all. So community meetings and many rounds of community meetings. And in these photographs, you can see that my daughter and her friend also accompanied, so that family feeling will be there. So that's why. And then this kind of dancing in the field and those kind of things. So that is very important. It was not very difficult for people like me who have a lot of friends. So whenever I go, I make friends. So that way, it all took all these turns. And now, then when we wanted to launch the intervention, it was used and it was big level launch. So you can see all the ministers, commissioner, collector, all present, health department. So it was a multi-department, what you call grassroots level convergence. So that kind of ICDS and those function, these officers are there, mantris and mantris of the local other leaders were also there. So then I because Udaipur is a district where this destination wedding and it's a tourist district. So they have a lot of perception, good fancy perception about the hotels, Taj and those lake palaces. So invited and pulled in the chef from Taj Lake Palace, and they came down to Jharol, and if you can see that they are we organized live kitchen shows by using millets and millet laddu. So all of them, and then that day we basically treated around more than 1,000 women and children from that area, and all millet recipes prepared by these chefs. So so that they attach that pride to those millets. They'll not so it was very important to change their perception. Then we organized a seed sowing festival, and wherever we met them, we made sure that met them in fields, okay? That fields are our friend, and fields support us, nutrition, fields support our well-being and all, so that, because leave about supplementation and whatever, all other nutrition intervention of providing supplementary nutrition or this ready-to-use things and all. So it did not work. Basically, it was till the time the kind of, I'll just shorten it. So till the time those interventions were there, and that is, so sustainability of any effort was very important. So then we tried and explained the communities about how it is good for environment, how it is good for their livelihood, and how it's good for them and their children. So we organized that seed sowing festival on large scale, and we invited all the influential women and those whom they see frequently, on TV and things like that. Even collector and administrative officers came to those areas, and they started, and see the collector is sowing the saplings in the field, and they all followed, even involved children, school children in that campaign. And see, this is the gathering of the women farmers, and how they are learning the live kitchen show. This lady, I'll love to talk about her. She, in the process, she gained so much of confidence that this old lady, without knowing the language, she cannot converse Hindi properly, and she came at the stage, and she took mic and she spoke about the nutrition and those things are required. Then that photograph, you can see that that professor from Ireland. He's a chair of lifelong learning and of Europe, and then came with his team and saw everything closely. Even he tasted the lady cooking food, this ragi roti, and he had by just joining at her house. So all these gave a good level ownership, and it built the environment, which was the most, like tedious task. So collector is encouraging them. Then Sanjeev Kapoor, that celebrity chef, he also came down for this promotion, and so that, it builds the environment properly. And to me, yes, I'm just doing that. So instead of, providing something supplementation, even Rajasthan Agricultural Research Institute, they offered this fortified pearl millet to us that you can roll out with food prepared by fortified kind of pearl millet, which basically from the germination stage only. But we refused because we had to promote that traditional micro millets in those areas. And I think next year some kind of yield, some more supply of those cereals will be there in that pocket. So I think that's it. And thank you very much. Probably next year, if any of you, talk to me, and I'll have more facts. So it's it's important. It's important that we start saturating, and we start practicing such exercise in small area, and it's very much scalable. So you have to just connect with the community, and we have to understand them first before telling them what we want from them. So that it works. Thank you. Thank you so much.
Thank you,
I'm
Varsha.
sorry
I think
for extra time.
no, that was great. I think I think you highlighted a very important point here, that making policies is one thing, but then implementing policies and communicating the implementation of the policies and bringing that social behavioral change is a very important aspect of it. Otherwise, everything fails. And I think you've sort of given us an insight here where you became a chef there, you became them for a part, and then you also brought the celebrity ambassador there. So I think you've tried all sorts of angles to make sure that the social behavioral change, which is one of the most difficult things to achieve, gets somewhere. So thank you, Varsha, for that insight. I think it really sets a good tone for taking our conversation forward, because I'm sure even for this work you would have raised some funding as well, right? So I want to really address the elephant in the room to start with, because everything starts with funding, especially in the development sector. And nutrition is one sector where both private sector players and public sector players are hugely invested. And if I may start with you, Natya, then on that front, I think with IFC playing a key role in let's say, strengthening the private sector ecosystem. And if I was to just sort of put myself in the shoes of a businessman, for me, profitability and making sure that the sales are on track, et cetera, would matter more. Although now that I know nutrition, it might change. But for most business people, the bottom line is what would matter. How do your investments or your investment strategies encourage a nutrition thinking in the private sector?
Thank you, Ankur. It's a pleasure being with this nice team here, and it was such an interesting and important event in Delhi. It's first time for me here. Unfortunately, I don't have much time to explore this city, but I'll be in Mumbai next 2 days, and we'll try to find out, and we'll be back here for sure. So, as you know, IFC is the International Finance Corporation, part of the World Bank Group. IFC mostly work with the private sector, while the bank itself works with the governments. The group includes, like World Bank Group includes, in addition to IFC, MIGA, and also funds, which is also supports both private and public sector. So as IFC, we mostly last 1 year, in fiscal year 24, we in agri-sector invested around 4.8 billion. And that's a huge numbers. I guess that is in this year we achieved the maximum what we invested last like many years. The thing is that even from this agribusiness investment, we specifically also like screening our investment in nutritious products. And last 5 years, we've just like that day before the Nutrition for Growth Summit in Paris, where we both participated, we looked at it's around 2 billion what we last 5 years invested in nutritious food. So it's not only the millers, correct? Because of miller investment, it's around so 1 year investment, 5 year investment is around 300 million in miller businesses, while fortification specifically are looking to the companies who are fortified, it's around 200 million, which is a huge numbers what we are talking, but we still believe that it's not enough. That's why World Bank jointly with the IFC committed was Nutrition for Growth Summit for around 5 billion for next 5 years, and that 5 billion not goes to the governments only, but also we are committed to work more with the private sector to incentivize them, to help them to have some interesting projects in a round of nutrition. And as I'm mentioning, it's not only for fortification. I know that today we are talking on this topic, but we also look more broadly on that topic. So collaboration is important, and whenever we are doing the project, it's also important to have the realignment with the nutrition goals whenever we are investing, and also have the nutrition as a part of the strategy pillar in the agribusiness, because I represent the department which is agribusiness, we're calling mass marketing and manufacturing and services. That's an important part, to have the goals of nutrition and then align that with the investment strategies. Thank you.
Natia, thank you. I think it's very heartwarming to hear about the commitments from the World Bank for the next 5 years. Did you say 5 billion commitment
5
for
billion,
the?
yes.
That is incredible. I think it makes a large chunk of the $27 billion investment commitment that has happened at the Nutrition for Growth Summit recently in Paris. So it's quite a sizable participation from World Bank. Thank you for that. So building on, Natia, your sort of commitment to including nutrition in your investments, if I may move to Ruchika, then another key stakeholder on the investment side. Ruchika, you at the Gates Foundation have been working very closely on the government agenda primarily, and you've been helping to shape budgetary priorities that would support a wider range of nutrition interventions, addressing the nutrient-dense foods for SAM children, unprocessed and whole foods, behavioral change that Varsha mentioned, and food system transformation. So could you give us a little more insight into the thinking of the Gates Foundation on that?
Thank you so much, Ankur. At the outset, I would like to thank the organizers for such a, I think, insightful and intellectually stimulating conversation we are having with the fellow co-delegates. At the foundation, it's key when we work in countries, we work with agenda which is really important to the country when it comes to addressing any health or nutrition or developmental issues. We really see when we are talking about investments, along with the financial institutions, as one of the philanthropy partner, we can play a pivotal role. Working alongside with the government one is focusing on the interventions which impact nutritional outcomes, and really focusing on the nutrition sensitive and nutrition specific interventions, which includes, as Ankur you mentioned, IYCF, nutrient-dense foods to address wasting, also looking at the current pandemic when we talk about malnutrition, which is not only undernutrition or overnutrition, but also multiple micronutrient malnutrition. So apart from focusing on traditional programs which the government is running, it's also really important, and there has been a clarion call from the Prime Minister of the country talking about obesity and how that could be addressed. So also looking at the preventive measures, which becomes really important. We have another session happening parallelly in another room called Let's Fix Our Food. So really looking at how we can focus on unprocessed food, whole foods, looking at preventive measures like reducing the intake of high fat, salt and sugar, and also looking at, as Varsha mentioned, the behavior change component as well. So really important to look at how we could look at various interventions in a very holistic way. Again, government is the one who is the major driver of investment in the country. As philanthropies, be it IFC, be it World Bank, be it foundation, we are really kind of contributing to the iota of investment. So really want to place that. But where we could play a role is really catalytic in terms of designing investment cases where the investments are needed the most. So that's really important to not only impact the economic outcomes, but also looking at the human development outcomes when it comes to cognitive impact, but also when it comes to workforce impact as well. So I would like to share some of the examples in terms of our work with World Bank and really looking at results-based financing when it comes to interventions relating to maternal and infant young child nutrition, and also looking at some of the investments relating to ensuring dietary diversity. The other investment I really also wanted to call out is with UNICEF. It is the Child Investment Fund, wherein we are partnering with other donors, including Child Investment Fund Foundation UK, to also look at how we can play a catalytic role in terms of ensuring that there is enough finances when it comes to both supply chain of various interventions when we are looking in terms of addressing wasting. So talking about products when it comes to wasting in terms of nutrient-dense foods, and focus on high priority countries. So for us, bottom line, I would really like to give key message is that foundation plays really a catalytic role when it comes to government. They are the major in the driving seat in terms of investing. So just to place this in context is India invests around $25 billion every year when it comes to the food safety net program. So our investments, or when we work with the financial institutes like IFC or World Bank, is really an iota or catalytic in terms of investing on priorities which the countries need the most. Thank you.
Ruchika, thank you. I think you mentioned that even though it may sound a tiny portion of the large investment, I think you play a critical role in catalyzing those larger investments to make that impact that those larger investments desire eventually. And so on that front, Neha, if I may come to you, I think you, for example, have been thinking a lot about nutrition-sensitive strategies such as dietary diversification, reformulation of products, supply chain innovation, and all sorts of other things that would make the investments commercially more viable, both in the private sector and also on the government front as well. They look for a decent return on their investment as well, so their buck goes the distance. So what is it that GIZ is doing in that space, if you can give us?
Yeah, thanks Ankur for this question. So I believe we are GIZ on behalf of German government, we are working and implementing global programs. So I would say in regard to special initiative which fall under transformation of agri-food system, we are working in this space from almost many decades, and coming to the specific experience from the global program which is on securing nutrition, enhancing resilience. We are working on nutrition sensitive integrated approach. So I would say definitely to pick up from what Dr. Varsha has mentioned about community engagement, that play a very crucial role when it comes to nutrition sensitive integrated approach, bringing social behavior change driven nutrition education for the community, and at the same time we are also linking it with community nutrition gardens. So looking at this whole pillar of nutrition security, from availability, accessibility to utilization of nutritious and diverse food. So that is really one of the piece which we are working at scale in the state of Madhya Pradesh and also in Maharashtra with the government department. So the entire work around GIZ is with the government of India and mainly with our political partners. So here we talk about the Ministry of Women and Child Development and working closely with under Poshan 2.0. So I would say yes, it play a very important role to create awareness, but at the same time, when it comes to supply side and policy enhancement, so GIZ play a very crucial role in doing policy advocacy, linking it with our implementation at the ground, and then also advocating with the government to strengthen the existing government policies and programs, and also working toward the supply side market linkages, because this whole aspect of food systems is not only to create awareness and demand generation, but also linking closely with the supply side and the government policy enhancement. So we are really doing our bit, but as Ruchika also mentioned, that government is the driver in this whole aspect of nutrition security and also making this micronutrient deficiency reduction programs. So we are trying our best and working as a catalyst also on behalf of German government, implementing several programs, not only on nutrition, but also on environment, sustainable development and biodiversity programs, so that we can see this whole nutrition security in a holistic way. So I would stop here, Ankur, and then we'll be looking.
Thank you, Neha. I think the role, that linking role or the anchoring role that you play is really important, because there are so many stakeholders these days addressing a single problem that if they don't work in a collective manner, I think it becomes a duplication of effort in so many ways. You mentioned being helping the government be a strong driver of it. I think the role in a way that you play is ensure that the driver is not drunk while driving, so that it gets to the destination at a reasonable pace. But at the same time, if I may come to you, Danny, then using the driver analogy as well, you also make sure that the driver is well trained and has really passed the license test in a trusted manner. And if the driver was to then shift from a manual vehicle to an auto vehicle, you've been helping sort of set the center of excellence model for countries including India. And what is it that the private sector could learn from that experience and could really leverage from that center of excellence model that you're helping build?
Thanks, Ankur. Yeah, so when we were implementing this food fortification program, particularly on rice fortification, when even before government was putting it on a large-scale mandate, when the pilots were running in, one of the biggest question that was there in the room is how we are going to address the supply of fortified rice to almost around 700 million of the population. Are there stakeholders ready? Are there private manufacturers who are there set in place who will be able to come on board to address the distribution and to provide them with kind of a technology and help them to provide or process the fortified rice, having all the technical aspects on place in terms of quality and the mechanisms to produce fortified rice. It was a big question, and once, like the way you mentioned, that the driving force, there was a commitment from the driver that yes, I will take you to the destination and we'll place you on board where we need to arrive. The private players were hugely coming up. There were systems developing rapidly, rampantly, and most of the manufacturers were starting to put the systems in place. And when this FRK manufacturers or the private players started to produce the premix, the FRK, and FRK in the sense the fortified rice kernel, which is mixed with the normal rice, there was also a need. There were development partners in the field who were providing them with the technical know-how. Also, government was developing a lot of operational manuals for the manufacturers how to produce the facilities. Simultaneously, we were also thinking that there should be technical institutions. There are a lot of technical institutions of national importance in the country, which plays a major role in development of technology, which IIT institutions like IIT Kharagpur, which was also working on this rice fortification, and Central Food Technology Research Institute, which is in Mysore, which was working on this food fortification and other initiatives where they were more keenly engaging with the private players as well. So the idea of collaboration is that in terms of sustainability, once we reach the destination, how the sustainable mechanisms will be put in place, and that was the key concept through which this Center of Excellence emerged. And one of the most of the important institutes of national importance, like the NIFTM, which focuses on the policy as well as the entrepreneurship and the private players development, and the Central for Technology Research Institute, the Indian Institute of Technology, Kharagpur, and the IIT Delhi. And most importantly, the last piece, the capacity building. Who is going to take care of the capacity building of all the players? The Food Industry Capacity Skill Initiative, which is under Ministry of Food Processing Industries. They were also brought together and their conglomeration was formed, which is now put in place, and they are supporting the government, the states, and also we also thought the Gates Foundation played a very supportive role in bringing together this mechanism, where when we were working in the states, bringing together state universities as well, so that there are sustainable mechanisms put in place for the states to engage with the private millers, the private players, as well as for the state governments. And there's urban spoke model at the national level as well, through which they communicate and contribute for the betterment. I'll just pause for the now.
Thanks, Danny. I think all of that you went through in just one breath, I think that is a lot of work. And I think if anybody wants to understand the magnitude of the work that PATH has been involved in with the help of partners like the Gates Foundation and GIZ and others, it's really phenomenal. I'm myself just learning for the last few months what all we have actually done in that space. So Danny, you mentioned strengthening of institutions is really important, and I think that sort of connects quite nicely to my next question about sustainability. And if I may shift gears and come to you, Supreet, on that, GAIN has been working a lot in designing food systems transformation for real impact, and sustainability is a key part of achieving that real impact. What is it that GAIN has been doing, not just in India, if you can give a sort of broader view on that from the Global South perspective as well?
Thank you so much, organizers, for having me here. It's a really very learning experience, and I think a very great platform to share the great work which is happening around the sector. So as far as Global Alliance for Improved Nutrition is concerned, we work a lot in food system transformation, and especially addressing the key challenges which are related to nutrition, which are related to food system transformation, the sustainability, the supply chain management, and so on and so forth. Our biggest portfolio is large-scale food fortification. We work with the staples like oil, milk, and wheat flour, and we are fortifying it with the essential nutrients to help the vulnerable populations to combat the hidden hunger of micronutrient deficiencies. Along with that, we also work very closely with central ministries and state governments to ensure that large portion of the staples which they are eating, if they are fortified, they have to be ensured the quality fortification has been done, and the products which are reaching to them should be of the appropriate quality. We also support government in standard settings of the optimal amount of fortification to be done, which again ensures that the micronutrients are reaching to the vulnerable populations. At the same time, we not only work from the government side, the other aspect is we work very closely with the industries and build their capacities and collaborate with private sector to handhold them again to ensure that whatever produce is being done is of the appropriate quality, and which are cost effective also, and again sustainable in the longer run. The second major aspect on which we are working is the strengthening of the supply chain. We work in a very remotest part of Assam. We work with tea states there, and as Dr. Varsha was mentioning, that how in very hard to reach areas, people's nutritional score is very low. The diversity scores are very low. When we reach there, we find that one of the meal of few of the families is just a chapati and a black tea, because the food or the nutritious food is not available at all. Even if the pulse is available, that is only for one variety. So we work there, we built the complete supply chain of healthy and nutritious food to reach at the last mile. And over the work of years, we now find the diversity scores have significantly improved for the vulnerable population. Milk, eggs, fortified oil, and other food basket components have really improved in that areas. That again is through the behavior changes and ensuring the supply chain strengthening. So this gives again a sustainability angle to the whole work. The next major work which we are doing is with the government of Bihar, where we are working with, providing the fortified take-home rations. We are building the skills of the self-help group women through Jivika. Through this, we are not only ensuring the nutrition is reaching to the vulnerable population through ICDS program, but also building the capacity of the females who are working in that industry, so that they can be financially independent and at the same time can again take care of nutrition, education of their children and themselves. So this is the whole gambit of, a complete picture of how we are working in India and at global level to support the food system transformation at right from the farm to fork approach, whatever is being grown, how we can tweak it and finally can improve the nutritional outcome of the people who are working in that area. I would like to stop here. Thank you.
Thank you, Supreet. I think you touched on an important aspect of availability not being enough, and I think getting that access element enhanced is something that really makes sure that the food becomes part of their nutrition and diet. So I think building on that, we talk about getting food to people on the ground, social behavioral change that's required. If I may come to you, Varsha, on that, you've been working a lot. You showed us some work on your social behavioral change and how you are bridging food security and nutrition security. How do you think institutional partners can ensure that the security angle of nutrition is meaningfully integrated into the food policies and programs, so that access to food also translates into dietary improvements and nutritional indications being met?
Yeah, so good question. Because the challenge, basically the goal is, because as I finished my talk, so probably I think Ruchika asked about the budget or something. So basically I'm working with the tribal area development, this budget for carrying out research. Which was not used for 2-3 years during pandemic and COVID. So I was lucky to get that, at least that part of this thing is there. And then basically the main challenge that, is connecting the dots and putting all the boxes in straight line, which you want ultimately, because, it's like once or twice or thrice not possible, then some kind of this challenge basically, that is there, that you have to do it. Because many times it feels like, no, leave it. It's not possible here, maybe, some other place. Because, and last year was 2023, was the election year for state and for central election also after some time. So 4 rounds of administrative officers got changed. So the, telling them and sensitizing them about the things what we wanted, because even if you implement at micro level, only 3 blocks and 2 panchayat every blocks. So only that, but that also require, hand holding from various department, and what you call convergence is a big word, but then even if cooperating with each other, Rajivika was there, rural urban livelihood mission, because those tribal women, so community engagement and also they were instrumental. Then ICDS, these Anganwadi workers and those people were also there, because then it is there is a different kind of channel which is called Mabari Center in tribal area development institutions, and so there you get below 12 years of age, children. So it's like daycare center, and food is also provided, like midday meal and this breakfast and all. So channelizing, they were the first straight targets, you start channelizing things. But then also procurement was a challenge. So in spite of there are very, I don't want to name, but very renowned, CSR, and those companies are there, but on CSR, they have their own agenda, so nothing on nutrition. So, or even if nutrition, they had their own this thing. So, channelizing fund policy and those, putting everything together was a real challenge in a very meager and such a micro level. But secondly, one good news is that after so much of hue and cry and then following them, at least some kind of bright rays has happened. So this year in the budget announcement of the state, so recipes, it was line of the budget announcement put absolutely the line which are meant that the recipes made by millet will be served to Mabari children, and that's in the budget announcement. So the policy, yes, includes, but it's very hard to convince them. And they'll see that you're burning midnight oil and you're always available for even the shortest kind of, organizing events and so many things. So then it works. It worked in my case, this case.
Wonderful, wonderful. I think getting a budget line introduced is a huge achievement. So I think thanks for that. I think I will come to the climate angle, since you mentioned the tribal area work that you do, and I think these vulnerable populations and remotely located communities are likely to be the worst affected as the climate is changing. So I want to shift gears slightly and move to the climate and nutrition topic, because not a lot of thought is done, is given to the process of how that would be addressed, but a lot is talked about climate impacting nutrition, but how you would address it is something that's not being talked about as much. And then sticking to the budget line question, I think if I may come to you, Natia, from IFC's perspectives, what are the key factors that your institutions and your team considers when you're deciding on nutrition interventions and investments in different country settings?
Thank you for the question. So there is a different aspects what we are looking, starting for the country-specific gaps on nutrition. Also, it includes the policy regulations in the country, private sector readiness, consumer demand, also scalability. So there is also data-driven aspect what we are looking, correct? So when we have our strategy in each country, every country where we are investing, and IFC has an offices and World Bank has offices in 184 developed countries. So you might understand how big is like scale and how we are looking on that. But the thing is that, as I mentioned, in addition that we are investing a lot, we are very closely working with different partners, and Ruchika mentioned about the Gates and IFC collaboration on nutrition topic, but not only. We were 3 weeks ago in Seattle, met with the Gates Foundation agriculture team, which is a different team, and also food systems like team, also different team, and Gates Foundation, and talk about different aspects. So when we are also connecting the nutrition plus climate here, I want to also mention that, as you might see, I'm leading also food safety, food loss prevention, which is all climate related things, correct? And fortification, like 3 different areas at IFC. And through the other interventions, we're providing advisory services. So IFC not only invests, that's what differentiates us with the other maybe financial institution. So we are financial plus development institution. So whenever we are investing, we are looking, analyzing gaps and understand what this private sector need is, specifically where we are investing. If there are some improvements needed, and we are providing advisory services through our donor partners, which is in one case Gates Foundation, specifically for fortification project, which we have run last 1 year at IFC. So yes, there is a different aspect what we are looking and how we are working. As I mentioned, specifically for fortification, as it is related to the like micronutrient deficiency and like malnutrition. This session specifically last like 4 years, we invested around 200 million specifically on the millers who are fortifying their products, but we think that it's not enough. We need to do jointly more and collaborate better. Thank you.
No, absolutely. I think you mentioned investments themselves are just not enough to convince not just the private sector, but also the uptake of the output of the private sector. And I think that's where the safety, and I'd actually use a broader stroke, their quality of the output really matters. We saw that, if I may sort of use my angle of public health from my previous life, we saw during COVID pandemic, for example, many of the vaccines that reached Africa through the COVAX program were declined, and they had to be finally binned because Africa demanded the highest quality of vaccine. So that cannot be compromised, even though the investments might enable production of food and nutrition for the community. So with that, I think sticking to the sort of funders' thought process, if I may come to you, Ruchika, on what is Gates Foundation thinking in this space, and how are you trying to enable the readiness for tackling the impact of climate on nutrition?
Thank you so much, Ankur. At the Gates Foundation, again, you know, when we talk about our nutrition strategy, it's very holistic, wherein the vision is that every individual gets the right nutrition to lead a healthy, productive life. And we really look at, when it comes to nutrition, is from, as we say, is from farm to fork. It's not just recently, but also there has been very intentional thinking in terms of what are the impacts we are seeing when it comes to climate change, right from the impact on production of various food commodities, including rice. I'll give an example where, because of the climate change, the nutrition quality of rice when it comes to micronutrients is lower than what it was in the past. Also, with the impact in terms of, and I'll give an example here of India when it comes to the soil, is the impact over the years on soil when it comes to contaminants. There has been increase in heavy metals in the soil, but also what we see is with an abuse in terms of the soil, wherein many of the good practices which were followed, say, 5 decades back, are not being followed in terms of crop rotation and others. We also find many of the critical micronutrients are lacking in soil, and here case in point is zinc, which earlier we used to get through cereals, through fruits and vegetables. If you go, and I'll really challenge the audience here, is go and get your blood test done. I think many of you will be deficient in zinc if you're not taking supplements. So it's really important to look at nutrition when it comes to, in a very holistic manner, when it comes to climate change, and that's the thinking at the foundation as well. So as we are working very closely with the government in terms of prioritizing program, right from our work with our agriculture teams, which are working very closely with the governments, they are looking at climate resilient agriculture and farming practices, and also then linking it into the micronutrient intervention programs to fill that gap. So the recent work which we also kind of worked with ISI, wherein the National Food Consumption and Expenditure Survey reports clearly highlight that the intake of cereals has gone down. So case in point, I'll give an example of Rajasthan, since we were also hearing from our fellow participant in terms of in Rajasthan, most of the iron comes from cereal. And we all of us know the bioavailability of iron in cereals is low. So how then this impacts in terms of anemia when we kind of correlate with the NFHS data? It makes sense because anemia is high in Rajasthan. So really looking at dietary diversity, the agricultural practices, how we can increase the production and then its access of nutrient-dense foods. And while this is happening, how various micronutrient intervention programs of the government when it comes to supplementation, fortification plays a role in terms of bridging that gap as a medium-term strategy becomes really important. So just wanted to outlay this context, and we'll talk more as we go.
Thank you, Ruchika. I think you talked about medium-term sort of, because I think connecting with your previous statement on catalyzing the effort of the government. If I may shift to you then, Neha, I think GIZ is thinking a lot on the scaling part of it. Climate is really a collective issue for us. It's not just for India, it's not just for our neighboring countries or the West, etc. So I think how is GIZ working to scale nutrition-sensitive interventions in the Global South, if you can give us some insights?
Thanks, Ankur. So yeah, just to touch upon on this aspect. So as I already mentioned, GIZ on behalf of German government is working on this global program. So it's not only in India, but also in other African countries and including Southeast Asian countries. So one of the area which we have really picked up is, since India is the front runner in a lot of areas, including the large scale food fortification with a strong regulatory framework and public-private partnership. So recently, some of you have already seen that video. So we had invited ECOWAS region, like 6 West African countries, and Sri Lanka, as well as Madagascar, who is also one of the country from the global program, to visit India and also to understand and see what kind of interventions are happening in India, which are really a scalable and sustainable model. So together with PATH and also in collaboration and co-funded by Gates Foundation, we did this exercise recently in January, and I would really say there's a lot of areas which we can exchange. It's not only we can learn, but also we can do cross-learning as well as scalability of those models. And 5 such areas which I would say, like, I would still again come up to this 5C model, which we has really touched upon after 2 weeks of delegation visit in India, moving to Jaipur, from visiting private sector to Mumbai, looking at a school feeding program also in Delhi with the IIC, IIT, as well as with NIFTIM. And as Danny also mentioned, the delegation was really very excited to see lot of interventions around large scale food fortification. And I would say there were 5 model which they would like to really implement as well as scale up in their own country context. Would be like, one is community of practitioners. So to create such institutions like ECOWAS and WAHO can play a role, like West African Health Organization, to come up with this regional harmonization of standard in regard to food fortification. And then second C would be on center of excellence, which I would say like India is really front runner in most of the area. Again and again, I'm emphasizing this because now we are having Ethiopian delegation visit happening in India from tomorrow onward. So NIFTIM institute like IIT, IIT Kharagpur, IIT Delhi, they are really doing quite an extensive work on innovation, like policy, technology innovation, which can be picked up and can be taken up by other countries. And third, touching upon this capacity building, third C would be on capacity building, where we can strengthen the local stakeholders institution around local capacity building to pick up like how to produce locally the fortified rice or other fortified staple, including premix. And fourth C would be around consumer awareness as well as communication, because that is where the key aspect where we can play a very important role coming from the international and experience, how this communication strategy as well as bringing a lot of social behavior change communication can create more demand around fortified staple as well as diverse nutritious food. And last but not the least is collaboration, where we all are working around. So these are the 5 C's model which we have really come across during this Global South Exchange, and we are working together now to bring that into action. And I would say thanks to PATH team as well as Gates Foundation for bringing this really the extensive Global South Exchange, which is sometimes sitting in this kind of international conferences doesn't bring that kind of insight and enlighten the thoughts and processes, but when we go really into the field and look from our own eyes, that really bring a lot of difference in demonstrating such interventions happening on ground. So I'll stop here with this 5C model, which we would like to pick it up from the recent Global South Exchange, but also some of these scalable models can be taken up from India to Africa, as well as taking the learning, cross-learning from other African as well as European countries. So I'll stop here as well as from US. So yeah, thank you.
Thank you, Neha. I think I was right in saying, passionate Neha. If you can remember all the C's that you went through, I think it's really impressive and very, very important to have all the C's addressed to really make impact on the ground rather than sitting and talking about those things, which is also important. Not to say that our gathering is not important today, but I think really translating that to the on-ground effect is what matters the most. If I may then quickly shift, I know we're running out of time, so just a minute to you, Supreet, if that's okay. If you can talk about what critical evidence gaps remain in the understanding of impact of climate change on nutrition outcomes, because there is very little understanding around that.
Sure. So as far as India is concerned, we are at a very crucial juncture where, climate is affecting our health and nutritional security of the vulnerable population especially. In this room, I think we all know that climate is affecting the nutrition, but where is the evidence? Although there are some global studies, but still, when we talk about hardcore reality at the ground level, the evidence doesn't exist, which connects the dot. Like for example, Ruchika just mentioned that, the nutritional content of the crops is depleting. There are some evidence which talks about that, increasing CO2 levels or increasing temperatures are affecting the crop's nutritional value. But that is not connecting to actual nutritional our very high-end programs like ICDS and midday meal, which talks about nutrition so much, but in the light of nutrition, when we talk about climate shocks like heat waves, like floods, like droughts, these programs are not still sensitive enough to tackle these type of problems. That what needs to be done at the time of if some climate shock happens to a place. So some sensitization for the government programs and change in some policies when we talk about climate is still missing, and evidence needs to be built to support the policy makers for the same. So very briefly, if I can talk about GAIN's integrated climate and nutrition program, that is a global level work which we did and we translated at India level, with the goal to develop and share the robust evidence based on integrating nutrition, climate and agriculture. So this is basically all the policies and programs which are either government led or government supported across all the states. And then we say that what is actually missing if we talk about climate related programs or nutrition related programs. And we did a complete landscaping of the country. And when we present these findings to Ministry of Agriculture and Farmers Welfare, they really liked our idea, and they are also in process of developing climate resilient frameworks. So that is a good thing. Now nutrition is finding a space in climate resilient framework. And we are serving as a technical partners to Ministry of Agriculture. The impact which they are seeing is they want to touch around 50,000 villages through 10,000 gram panchayats. So this is the vision for next 3 months, and we are working very closely. And in due course, I will be happy to share the further findings in coming time. Thank you.
Thanks, Supreet. I think evidence is critical for any funder to really invest. And I think both IFC, Gates Foundation, and GIZ always ask for evidence before making decisions. Right? And I heard firsthand at the Nutrition for Growth Summit as well. I think the evidence that GAIN presented around the value proposition of even the fortification was really very, very impactful. So finally, Danny, I know you can finish things very fast. Just a quick question, then I want to give 5 minutes to the audience if there are any questions. For evidence generation, you wouldn't require technology advancement, right? Could you also tell us, because you come from that kind of a technology background, you've helped build that rapid evidence generation technology. Could you give us some insight on that, please, Danny?
Yeah, so in terms of technology, Ankur, mostly in terms of relating to climate and nutrition, um, most of the aspects in terms of advancements needed to see how that addresses the climate. And one aspect which also GAIN, I was attending one of the events which was organized by GAIN as well, is that in terms of cultivation of paddy, where they go for direct seeded paddy, where the water consumption goes low. So that is one of the technology related intervention that addresses the climate aspect as well. And the other thing is mostly the field level requirement is the rapid testing kits or the rapid testing devices that needs to be at place to see whether the water quality, how the water quality is, or how the products that's been developed, whether they are meeting the nutritional needs, and what they're actually saying is whether it's present in the product or not. Is those kind of technologies available in place to quickly address the need, and more importantly, to make there are technologies available. There are, but the technology readiness level, at what level that technology is being developed at, and how quickly that can translate into commercial space to be put to use, is one thing which needs to be taken care of when we are thinking about any sort of technology to be taken into account. And also the most important thing is addressing the 4A's: the availability, the accessibility, affordability, and in terms of the final awareness. Addressing both the nutrition sensitive and the specific approaches should go together. It's not one after the other. So addressing whether if you are focusing on malnutrition, the therapeutic food products, as Varsha was talking about the local foods, using the local specific ingredients, how that can come quickly to place, so that we talk about the global south, including India and other Southeast Asian countries or the African countries, where they'll be not depend upon the global north for the product to come in, but developing their own technologies for their own locally grown products, where the private players are also well equipped to take up this technology. So we need to quickly start thinking and pivoting towards this direction, so that the global south countries are also talking to each other. They get the idea of how we can communicate with each other for the transformation of the knowledge, and there is an hub or something where all the information is available, so that they'll be able to quickly move in the right direction and get the success that they wanted to.
Well, Danny, I think since you mentioned 4A's, Neha mentioned 5C's, I probably need to work on some B's now at some point. Let's see, Danny. I think that's really important. You mentioned that the technology availability versus technology deployability are two very different things. Any questions in the audience? I'll take a.
Nutrition related awareness and programs. I tell you, FSCCI last more than 3 years, there is a proposal, draft proposal on the star rating of food products, preparatory foods, which is pending still now. Matter gone to the Supreme Court, again it is the PIL file and still pending. Point number 2, this in 2000, 1 minute, please allow me to. Yeah, my name is Giri Sethi, and in 2022, the Food Safety and Standards Amendment Bill 2022 was put up in the Parliament for approval, draft bill, and very, very important 2 lines in that. There is a that says, 1 minute, please allow me to. Yeah, that says all food products labeled under section 17E shall not be sold within a radius of 1 kilometer of educational institutions. Point number 2, very important. All food products labeled under section 17E shall not be advertised in the print, television, or any other form of targeting children, but still it is there. Whether you take Coke, I don't want to take any other food, sweet drinks. These 2 important bills for the last number of years still pending, and we are talking about the nutrition.
Yeah, thank you, sir. Another question, if we can take. I think you raise a very important point, and it needs a broader discussion.
It is discussed.
Sure. Sure.
But still it is pending.
Okay,
Venkat.
I'm Venkat. I'm with Path. I'm going to raise a question. You don't need to answer it now because I would want to give somebody else a question that you can answer. But let's say, I mean, one is great panel. I can look at a multilateral institution, a bilateral institution, a philanthropic foundation, an alliance, an implementing partner, and academic institution sitting here. I believe a government stakeholder would have completed the panel like anything. My question is to, let's say, assuming that you guys are fortune tellers, and let's say I am in a casino betting my money on the next big intervention that would take place in the nutrition space. One word answer, where would you want me to put my money for the next 5 years?
I would say transformation of agri-food systems.
So that counts for, climate-related issues and how we are.
Yeah.
Traditional eating habits back in a new
Yeah, so I would just go by evidence-based Copenhagen consensus. I think multiple Copenhagen consensus, which includes Nobel laureates as well, wherein a lot of questions were put across to these to the experts in terms of which investment you would kind of throw your buck when it comes to return on investment, which included trade, nutrition, and a lot of areas, climate, health, and I think repeated Copenhagen consensus report showed that investing in macronutrient interventions was among the top 3 investments in terms of ROI.
Any other one words from you, Natya?
Regenerative agriculture, which is absolutely linked to what colleagues mentioned here.
There is one more question and then we'll wrap the session.
NCDs and other diseases, how we are customizing nutrition around those diseases?
Thank you. It's a really important question, and as I mentioned, our honorable Prime Minister is, right now it's being highlighted at the highest level. NCD is a new reality, not just for India but for the world. And when we are talking about good nutrition, it's really important to think from the holistic perspective, not just in terms of addressing undernutrition or overnutrition, but also looking at how we address the NCDs, which is kind of linked to overnutrition. And here I would really call out behavior change. Communication plays a big role, and all of us sitting here know that this is the most difficult thing. So how we can ensure awareness and also inculcate those habits right from the beginning when it comes to preschool education. I'll say not only school education. The first 3 years are considered to be a critical years when it comes to habit formation. So how we can instill it in the first 3 years of life, but also ensure this awareness right in the school years, because again, I think youth plays a very important role when it comes to nutrition and how they can kind of shape, one is their nutrition, but also kind of inculcate within the family. Many of us are aware many of the ill practices when it comes to tobacco, and the recent NSSO data shows that the intake of processed foods, the pan, tobacco, and the substance abuse has really increased. And it's amazing, these are not advertised. So that peer education plays a big role. So really I would kind of focus our energies to that first 3 years where parents can play a role in terms of habit formation, but also the school age where again students can play a big role, and how we can focus on youth-led advocacy here.
One simple addition to what Ruchika said absolutely rightly. Millet, I think millet is another promising resort, which is good for addressing NCD, because having high glycemic index and compensating for all the nutrients, micronutrients. So millets, yes, of course.
Thank you. I think we've gone 3-4 minutes over time. Let me wrap up the panel then with a huge thanks to my co-panelists. I think it was a fantastic session, and we did have a government stakeholder also confirmed, but he had to go for a family emergency this morning, so it would have been a very complete panel. But thank you to all of you for your patience, listening, and keen participation. Thank you so much, everyone. Thanks. It was good. I think your comments gave me those connections. So.
Yeah, it was really nice. Very relevant discussion with this except government. I think we have a very strong panel.
Hello, can I request everyone who's attending to settle down, and you can come up. We won't bite, please. Lovely folks at the back, you are welcome to come up front here and be the front running students. Okay, let's get this rolling. If you can hear me once, please clap. If you can hear me twice, please clap. If you can hear me thrice, please clap. Did you guys have the burgers or not? Okay, so welcome to the human-centered design panel. Okay, the title is quite lengthy. HCD in health interventions, realities, challenges, and impact. It's quite a mouthful. We have a wonderful panel here today. We have Mohammad Shahnawaz from Khushi Baby here. We have Dr. Jalani from Who Sierra. We have Sri Rupa Sen Gupta from Swasti, the last one. And we have Samina Rahman from Noora Health. And I'm Prerak. I work with Dalbak Design, a human-centered design development sector studio. Today's conversation will be not very dry, will not be based on presentations. It will be a discussion where we want your participation, where we will talk about, of course, human-centered design in public health, but we'll also talk about practical challenges, the nuances of the system, how it is not a black box where designers do their thing and come out, but why is it an integral part, and what would the future look like for HCD in public health? So I'll just go back to my seat and get this on. So before we get started, I just want to show of hands that how many people here are human-centered design practitioners or classify themselves as HCD practitioners. Can we see you guys? We are typically a shy lot, so please raise it, don't be shy. Okay. And how many people here are really curious and maybe have heard the buzzword but want to learn a bit more about what is this HCD business and how do I put it in health? Okay, that's another half. And what about the rest? Have you been forced by your organizations to sit here? I would assume so. Okay, so we have kind of an equal split of HCD veterans and folks who want to learn a bit about it. So we'll try to keep a good mix amongst these two topics. And before we get in, and to make this a little more interesting, can we have like 3 folks share what do you want to learn at the end of today's session, and we'll try to incorporate it. We'll try to make it truly human-centric in that way. So can we have 3 folks? We'll just pick and quickly hear from you. Keep it crisp, brief. What's one thing you would want to learn today? End of the panel. Okay, we have someone there. Can we have a mic there? Is there someone who can help? Ma'am, if you can wait for the mic, yeah.
I would like to hear more about the challenges and impact which human-centric design created.
Okay, so actual practical examples you
Real-
want to
real
hear. Yeah, where it
examples,
worked. Great. One more, we have someone there, yeah. Got it. So resource constraint settings, short timelines, how do I make this work? Because we don't have infinite resources and time to do this like businesses. Okay, and one last, okay, someone at the back there, sorry, if can we hear? Just wait for the mic, I think. Yeah.
So I just want to learn how do we not force fit human-centered design into everything, and we
Great.
understand its true meaning, rather than just use it as a buzzword.
Right, like we don't want AI everywhere, we don't want HCD everywhere.
Yeah,
Got
just
it.
for the
Hear
name
you.
of it.
Yeah, great. So, okay, do you want to quickly just shout out before we jump?
How it's different from how it's like current session will differentiate between the current interventions and what is the value addition of this session.
Great.
Second thing is like currently most of the people are proposing One Health approach,
Right.
which has more interventions, how it will integrate with that approach.
Great. So One Health question, and the other end of the spectrum, what the other gentleman said, that everything seems human-centered. So what's the big deal, right? Like there are patients and there are people everywhere. Okay, great things. These are good things. We'll weave it into the conversation end of it. If it's not yet been answered, please raise the question. I'll try my best. So to begin with, before I get into introductions and panelists talk, what is human-centered design, right? Broadly understood. It's a methodology, it's a toolkit, it's a process, it's a mindset. And just like any mindset and toolkit and process, it can be learned. Either you go to study it or you learn it practically by spending years and years in it. You can gain sectoral expertises. You can work across sectors applying this thing, just like statistics or some other vocation. The difference being that a person or a set of people are your starting point of problem solving. And HCD in its current form, and I'm taking the liberty to acronymize it in this world of WHS and WHOs and UN acronyms, human-centered design, in its current form started during the Industrial Revolution, if people can trace it back. And then it became a means to sell commercial products. It's the times of IDEOs and frogs, these organizations, they brought it to very consumer electronic products and big businesses like Apple's and airline designs, etc., when this term became very boutique-y and like a new methodology to do. And it's only been like maybe 15, 20 years that its importance and its application to the social sectors has come up. And I would say it's maybe just been 10 years that in the health setting, the term has gained prominence through patient centricity, through consumer centricities, through citizen centricity, etc. And having this panel today actually is a failure. Let me start with that. Because if human-centered design was as integral to health as data privacy is to technology today, then we wouldn't be sitting here and discussing about it and raising awareness about it. So hopefully by the time 5 years down a WHS happens, we don't have this panel anymore because it's become an integral part. And with that, let me start with you, Mr. Mohammed. If you can tell what is human-centered design to you and how do you use it at Khushi Baby, very briefly in 2 minutes, and then we'll hear from every panelist.
So before I go to answer your question, I'll briefly explain what is Khushi Baby actually. So Khushi Baby is a digital solutions provider for frontline health workers. And we use technology to do a meaningful impact at grassroots level. So we use technology primarily, but we all know that technology cannot replace the human effort. And there's this interface comes and there's this experience comes. So for me, human-centered design is an experience. And this experience is something which in our use case is something which what ASHA worker at grassroots level understands, what ASHA worker at grassroots level experience, what A&M experiences, nurses at grassroots level, when they are interacting with the patient, the font size of the application, the calling system, the community engagement system, and so I'm using these terms assuming that you can understand when you deploy certain system at grassroots level, it involves lots of challenges, the language, the area where you are working, the community where you are working. So all this experience, if I'm able to improve in all those sections, I can say there's something which I'm trying to build a human-centered. That's all. That's all for me is meaning of the human-centered design, the experience. Thank you.
If you could also add.
Right. So at Khushi Baby, I can say that as I'm telling you, giving you one example. Suppose I'm taking example of Rajasthan, and Rajasthan is primarily people knowing it is a Hindi-speaking state. But even in Rajasthan, you have a cultural zones. So there's a Shekhawati. These are the cultural regions actually. The Hadoti region, Mewar, Wagdi region. So all these people and the village women, they cannot read and write proper Hindi, and they cannot understand even the Hindi what we are saying, what you want to say to them actually. And so our community engagement platform is completely we contextualize, we localize the whole community engagement process. Our automated voice messaging system is curated in Wagdi language, so that they can understand if her baby is due for the vaccination on next day actually, so that she can be prepared and go to the immunization center to get her child vaccinated. So this is one example I'm taking. There's lots other things that I can tell you during the process of discussion. Yeah.
Thank you so much. And let's go to Dr. Jalani. If you could also, the same question to you. What is human-centered design to you, and how does WHO promote this, right?
Thanks. So as a disclaimer, I mean, I heard this word human-centered design in healthcare really for the first time when my colleague pushed me into this session, and there was another session, and then but he said they would be more keen to hear your experience and all. Anyway, I mean, we're very familiar with people-centeredness, okay? And when I look at human-centered design, I'm thinking about people-centeredness. I'm thinking of keeping people, their needs, their aspiration, their cultural preferences, their caregivers' preferences, needs, and the healthcare providers, and trying to optimize and harmonize their needs and addressing them in the order of priority that people or patients ought to be right at the top and right at the center. In terms of examples, so, WHO comes with a whole series of guidelines, normative guidance and all, and at the back of front and center in all those guidelines, they try to make sure that people-centeredness value is reflected in those guidelines. For us, quality, I mean, or any policy, I mean, I look after, say, advancing primary health care. We look at the people-centeredness of the health systems. In terms of actual, implementation, I've worked with state governments and national government in the ministries of health and for over 3 decades. And there, of course, so when we were designing, we had the National Rural Health Mission, then we had the National Urban Health Mission, and this together became a National Health Mission. So in terms of, say, the timing, so unlike the NRHM, in the NUHM, we tried to see that in the urban settings, we had some engagement with the civil societies who used to work with the laborers, with the slum dwellers and all. And then they said the timings ought to be in the evenings when people come back from work. So in the urban settings, you will have the dispensaries in the evening timings and all that. I'll just give one example. The Laksha experiment in terms of privacy, in terms of dignity, etc., were all in the program thinking and conceptualization, people-centeredness, patient-centeredness was the key. Thank you. I mean, one can elaborate more on that, but we'll have more time to do that.
So I'll also briefly start with what Noura Health does, for those of you who don't know. Noura Health as an organization, we work in the space of caregiver education, health education for caregivers and patients, and primarily with the intent of empowering them with correct health information or that can help them make better decisions around health. They can help with patient recovery and in some ways improve health outcomes and reduce load on the health systems. How we do these things is we work with health systems and public health facilities where we work with state governments, or we work at a national level in some countries, where we work with the frontline health workers, nurses. We create programs that encompass a lot of aspects of health education. We create IEC materials, we create service, like digital services, and then we train these frontline health workers, nurses, with those tools, with that program. And then these nurses help conduct sessions with patients and caregivers when they are interacting with the at the health facility. So whether they're at an OPD, for an OPD intervention, or they are in the ward, utilizing those hospitals and those facilities to impart critical care information at that moment. That is what we that is what we do and deliver through the nurses. And then we also onboard them onto a direct-to-user service, which is a WhatsApp-based chat service that we have, where once they go out of the public health system, or they go back home, if they have questions, if they have worries, if they have things that they want to know more about, we still continue to support them with the intention that they're able to follow the correct health behaviors and correct health practices. In all of this work, HCD is absolutely critical to what we do. It's part of who we are as an organization, and it shows up in a lot of different levels of our work. So for us, human-centered design is not a thing that designers apply. It's part of the process. It's part of the outputs that we create. It's part of a lot of ethos. And what that means is we always start with, or always go back to, the users, the humans who are anchoring this system, or the humans that we are designing for. So when it comes to the IEC materials, there's a lot of care and intention put into making it relevant for them in their context. Right, when it comes right from like having language or visual contextualization from region to region, having different types of visuals, having specific examples of communication, stories, narratives, way to engage with different types of people, right from all of the communication styles to actual processes of even building the programs. So, for example, recently we launched a program in Nepal, and one of our starting parameters or starting activities was we had a couple of co-creation sessions with the health workers, with the nurses. We got a lot of topics. We went with what we thought we had in mind, and then invited them into a conversation to build the program with us. Like, what do they know and they understand are either their needs that they want to communicate, or what do they understand of the population and that is helpful to the population. So like this, we have many such things that are intertwined in the process of designing and developing our programs. But not just that, even when we are on the field supporting the implementation, supporting the growth and scale of the program, the whole ethos of every single person at Noura Health working for this cause is to help the other human achieve the larger goal. So whether it's talking to a nurse, encouraging her, that relationship is never transactional. Nobody in the organization takes that as transactional. Right from even working with like government stakeholders, which is also something extremely difficult, there are aspects that show up there as well, like how do we make it relevant for this human in the picture? Like what's in it for them, and how do we ensure that our program speaks to their needs in some ways? So at every step, we've gone back to crafting almost smaller design challenges at every step, and for every design challenge, we have a version of human-centered design showing up.
Let me just repeat, it's been a long share. What is HCD to you, and how does it show up in your org? And I guess at that point you can also share a bit about Swasti. Yeah.
Sure, thank you so much. Hi everyone, I'm Shri from Swasti, Shri Rupa Sengupta, you can just call me Shri, I know it's a mouthful. With the last session at the World Health Summit, so thank you for showing up. How many of you have been feeling very cold for the last few days? Raise of hands. Oh my God. Some of you have just been warm, like you're just warm people. Is that what's going on? It might interest you to know that the average temperature in which a human being thrives is supposed to be 20 to 26 degrees. Yeah, but That's also not equivalent to everyone. It's not studied for gender. Some of us, I can already see some people nodding like, I need at least 29. I come from very temperate climates. I need 32. So now, when we talk about all of this, when we are designing for human beings, it becomes very, very important to look at how the human being thinks, does, feels, and says, right? And to me, that is human-centered design. It actually comes from the empathy map. At Swasti, we just completed 2 decades. We're just 20 years old now. So we are a relatively newer organization in the newer kid on the block, relatively. I know that there are some of us who are newer than that. But what happened was, as a result, and how we were like really, really lucky, is that we came into the scene after human-centered design had already made an entry into the scene. So we were able to integrate human-centered design into everything that we did, from designing infrastructural spaces to doing what ma'am was talking about. I'm sorry, I didn't get your name, but in resource-poor locations, aap human-centered design ko kaise ground karoge, right? Where it's not so expensive, where we can do it. So we were able to do it at every level. Now what Swasti does is, Swasti means well-being in Sanskrit. And we are talking about our, you know, in very developmental terms, some of us are masters in social work, so we do have this vision, mission hangover. So the idea is to add 100 million healthy days to the lives of the most vulnerable. Okay, that's it. And we are looking at everyday well-being for everyone. And human-centered design is at the heart of that. And so that's what we do at Swasti. More when we meet one-to-one, okay? Let's get the panel going. Back to you.
All right, we need that energy in the panel. Thank you, Sri Rupa. I think I want to jump to one of the questions someone raised about resource constraint settings, right? And I'll make this very specific and targeted a question. One of the core tenets of human-centered design is we keep talking about prototyping, right? Prototyping, to prototype something, test something quickly, very rough, iterate, fail fast. And this is so counterintuitive to resource constraint settings. We are so afraid of failure because resources will go to waste, our time will go to waste. So, Samina, I'm going to put you on the spot and ask you this question. In your work, can you give a very specific example where this mindset of failing fast actually saved time, money, or resources rather than being seen as a failure in the long term? It helped you make it a big success in the long term. Yeah.
I think everything, I mean, there are so many examples, and everything that we do, there's a version of prototyping and testing that goes in for sure in that. I'll start with, again, a very recent example of how do we actually even proto-test it. Like you said, in resource-constrained environments, creating a prototype and testing can be extensive itself. For us, it's not about prototyping the whole gamut of things. We start with figuring out what are the biggest assumptions that can fall flat. Like, okay, we want to make a poster. This poster is going to be the biggest, attraction. Our biggest assumption here is that people are actually going to get up and look at that poster. That is the whole base. Like, and if we can make a massive poster with a lot of information, but if people are not looking at it, it's not going to work at the end of the day. So for testing something like that, we don't need a perfect poster. We don't need, a lot of correct information. All we need is as provocative or as inviting as we can be, as we think we can be, we create one prototype. And we recently did this. We created a prototype. We put it up in a facility. We got special permissions, yes. We put the poster up for a few hours in a facility, and we just observed. And what we saw was not a soul looked up, not a soul. And this wasn't a setup where people were like, this wasn't a setup which was with cognitive overload. So there weren't too many visuals on the walls also. But even in that case, even with these posters being very nice, inviting, visually appealing, people were not engaging with it. They were not looking at it. They were not reading what was there. And we also tested a couple of sizes. Like, okay, usually we want to do a small size poster. Let's just put it and see. And the expectation is it's very legible from like a 2-meter distance. And and again, our biggest assumption there was people are coming to a 2-meter distance or lesser. So we only tested for those assumptions. We did not test for everything else. Like, we did not test the whole gamut of, do they look good, do they feel good, is the information correct? We only tested, will people interact? And with that, when we realized they weren't, we sort of changed our strategy a little bit. We still wanted posters put up, but one, we went massive size. Second, we did not put a lot of very critical information, like we knew in our monitoring as well that these are going to be passive tools. And third, in the tool itself, we've put certain QR codes for scanning, so like an onboarding to the digital service, for us to have some idea of our people interacting with it. And when we've done this, we do have data coming in. We've just launched a few months back, so we do have data coming in from that QR scanning as well, that there are people who are going and scanning, but that percentage is very low. So something worked, but our overall learning of, investing a lot in having information on posters, and we learned we didn't need to do something like that.
Yeah, that's super helpful. Thanks. So you are saying failing actually was like a boon, if I have to paraphrase you, and it helped you in the long run put the right product out there. And in this case, it was a poster and information passing. I want to build a bit on this, and I'll come to you, Mr. Mohammed, that the example Samina gave is about a poster, right? Seen as a product, as an information that people can take back. Again, digital, there's a digital component to it. But when it comes to service models, like Khushi Baby deals with, and when it comes to extremely life-saving things like vaccination, how do you see this process? Because their failing is not an option, right? It can't be like someone read wrong, yeah, we can give them right information, but a wrong vaccine. This is critical stuff we are talking about. How do you try and iterate and have this feedback loop in your work? And if you can, again, give an example where you're able to do this even in this setting, that will be great.
So, thanks for asking that question, the resource constraint setting. When we started 10 years back, we are, 3-4 member team, just out of college campus, and we just went to a last mile situation, literally last mile, in rural of Udaipur, and this is predominantly tribal block, hilly areas, and we see ASHA worker carrying 10-15 registers, the nurses and all that. And when we thought of giving them a certain solution, digital solution, at that time when even ASHA worker was having enough the experience of the feature phone, not to speak of the smartphone. So yes, for the nurses they were using some smartphones and tablets. So we deployed certain tablets there. And when we started building the application, so that time we started with just a immunization tracking application. Now it's a platform with the 10-12 programs are running on this platform. But at that time, we were not having a choice actually and luxury to build applications and then test it and then again build application or build on that. We are having even at our level, we are not having enough resources, and we don't have enough bandwidth to visit field again and again doing. But we are stationed there. We are stationed ourselves there in the community, co-develop the solution. And what we did very intuitively that we did paper prototyping. So we do the sketches on the paper itself, like the screen of the applications, multiple the pages, and we go to the field and seek their responses. The health workers, okay, what is your response when you go to this page or follow-up page or then again a page? So they give an honest response. You don't need to build application to get their response. So it's a paper product, and that we failed fast. Actually, that gives a fast turnaround to us actually. And we spent like early 4-5 years specifically in Udaipur district, so that we should have enough experience of this resource constraint setting, so that we can have a curated approach, not just in terms of the experience, but other aspects of the community engagement. I just trying to give one example. How we actually experiences this process of the design actually.
Thank you. Again, very sharp, so really appreciate it, and in a very critical life-saving setting. I want to shift gears a bit from this. Another aspect of human-centered design, you might have heard folks in your orgs or around talk about is insight, right? Those needs or behaviors or challenges of people or patients that one finds out, and then that critically informs the way you are going to design a program, service, or a product. And one thing that I recall when I was building medical devices at a place called Embrace, with my friend Raghu, who's now leading Art Park and the AI Center, we remember spending so much time in neonatal ICUs because we were trying to develop something for low birth weight babies. And one thing was quite clear, right? Like the first call of action for the mother was going to be the immediate nurse. It was not going to be the doctor. So if we were going to develop some technology-based solution, which say was to talk about hypothermia, then where should the alert go? Should the alert go to the doctor? Should the alert go to the nurse? Now nurse is super busy, 100 things going on. And if you take a district level hospital, there are hundreds of births happening. How do we crack this? Now this is a great insight. Now we have a very sharply defined problem to solve for. And then you need all resources, right? It's not just HCD that can solve. So Shrirupa, I want to come to you with that. And if you could share one really, really core insight that you learned that shifted the way you were completely approaching a problem, and how HCD played a role there. So if you could give us an example there.
Not a very fun story, but let's do this. So at Swasti, I run a center for strategic communications for public health. And at the center, we are a bunch of people who really believe that communications can make or break your public health outcome, whatever you're trying to get to, okay? So we thought that one problem that we really needed to tackle, and this is our program teams who came to us and told us, is that Shri, anemia is something that we are struggling with. And we are struggling with anemia across India and the Indian subcontinent, right? Aap bhi haan bol rahi hai, right? So now it is also a problem which is unfortunately highly stigmatized. Jo samajh mein nahi aati most of the time. For a lot of us who come from very urban backgrounds, for us, why is it stigmatized? It's just an iron thing, right? But there are a lot of things. So we said, okay, fine. Let's take a poster and information approach, and we will go, it's an information gap. Because in our head, we were very confident that this cannot have been a problem where there is information, but there is some other stigma which is going on. So we went and dug deep, and I'm not going to talk about the region, I'm not going to talk about where this happened, geographically located. But when we went there, the women told us, thankfully we had community frontline workers among the women who were their closest friends. And when we sat down informally, without camera, without mic, no recording system, not in a room like this, they said, you know what? We are concerned that if our anemia levels go up, we will no longer remain fair and attractive to our husbands. And we did not see that coming from anywhere. And this is so different from what is taught in design thinking schools, right? And I'm sure you'll know this. We are taught this beautiful example about how a supermarket was entirely changed because of one housewife who was shopping. It's a very famous example in design thinking. I'm not going to run that example. I see many people frowning like, what nonsense was this? I wish I knew that when I was in school. But that said, one thing that we have to always remember, just like the temperature in this place suits some of us and not all of us. I see a very warm gentleman here who did not raise his hand then. Similarly, information and a lot of things that we assume do not really work. And wo dil pe patthar rakh ke hame manna padega. theek hai na? So we have to remember that even in human-centered design, who is the human is a major question. Which human is a major question. Even if we say cultural, geopolitical, geographical, all of that, who is the human is something that we have to really deep dive. Back to you.
Thank you. Again, sometimes these insights, like in design school, as there are some students also, it's framed as an aha moment, but when they hit you, it's actually not aha. The heart sinks a little because they are quite tricky to absorb, like the one you shared. Another one that comes to mind is once we were working with a firm, I'll not name, they wanted to increase hand washing in schools. This is a problem for people who do not know. Children do not wash hands with soap in schools. This is a big, big, big issue today. Especially more you go to rural areas, it's more prevalent. And they develop these beautiful jingles. They're like, we're very human-centric, we are children-centric, so there are these beautiful jingles. They're some of the best mascots that children will love, right? Like any part of the world, children would love these fluffy mascots, etc. But they say, we are just not seeing traction. Children have learned the jingle. We are generating local employment. We are hiring local folks to go to the schools and teach these jingles, and then teachers are on board and everything's happening. But one core thing was missing, and this is a bad example of not to be applying human centricity in each and every part. You have to apply it in the right measure, like a medicine, right? It has to be taken in the right dosage at the right time for the right problem, else we are having drug-resistant TBs out there. So that was a very good point. And what we found, and our project was to actually increase the adoption, but through the project we found that the soap and water are not at the right place. That was the biggest challenge. And that sounds so silly, and it took us presentations and presentations, because I work in a consulting firm, to explain that. And the soap, a very famous hand washing soap, they had done a beautiful job of packaging it, the most popular in the country today. And it looks so premium. So they packed it up in the cupboard. The same challenge with injectable contraceptives of women. They are locked up. You go to a public hospital because it costs 2,000 rupees to procure. Same challenge with insulin. You go to a public hospital, go ask for insulin. It will be locked up somewhere because it looks very expensive. Unless the soap and water are at the right place, there's no point. You can make the best jingles, you can have the best mascots, there's no soap available to wash. With this, I want to come to you, Dr. Jalani. Like a true HCD practitioner, he said, I know nothing, I'm here to learn. Is all of these talk we are doing, insights, products, programs, problems, they sit within a complicated system, right? It's not easy, even if I know this challenge, to move that soap from the cupboard to where the hand pump is, right? And at WHO, no one knows systems in health better than you. So this question is to you: how do you see this process like HCD sitting in the complicated global health system? And what are your thoughts on how can we make this an integral part of the systemic viewing of each of these challenges, and not somewhere in a silo lying in a golden box?
Thanks. I mean, I was looking around all examples around products and posters and things like that, and I was feeling at sea. Now, in terms of, as I said, I mean, we've not been using the word human-centered design because it's more in the private sector kind of thing. But people-centeredness, yes. I mean, we recognize that. I mean, our services are ultimately directed at people, and what is their experience with the services? Are their needs being addressed? So now, of course, there are many stakeholders, and then there are power asymmetry. So, you know, when I'm trying to reflect back in my both experience with the government. So, you know, even in terms of, I was mentioning about the timing under a new HM, you know, and this was because we were going to hire the contractual employees, and I said, we're going to hire them in the evening, it may be part-time, but they are going to be hired only for the evening. We are not concerned about, we're looking at the convenience of the patients, right? Because as of today, what we notice is that the hospitals across the country run from 8 to 2, 9 to 4, 9 to 3, may not be the most ideal time for people wanting to seek services, because they may be, they have employment, and many of these people, they'll run their private clinic in the evenings. So, well, you don't see that happening, but increasingly you start, you are trying to build in this element of people's voice playing a role in planning and implementation, etc. And I can give a few examples. You were talking about this issue, and it was about the alert part. And so during the lunchtime, I was talking to a very conscientious, compassionate, and technically sound neonatologist. So he was sharing with me the example of running a maternal newborn ICU. And he told me that he tried this. He was a professor in head in AIIMS Jodhpur, and they had very, very good result of having mother in the newborn ICU beside the baby. Now, nowhere in the country you are seeing, so you have SNCU, special newborn care units, where preterm babies, sick newborns are all, I mean, basically once are they in the hospital, generally around 1 day old, 2 day old, 3 day old, very, very fragile, very, very vulnerable. And he found that with this intervention of mother being there with the baby has resulted in improved outcomes, okay, in variety of ways. I mean, he gave 4 or 5 parameters, including on cognition, as to how even the head circumference there of the babies was growing faster, the recoveries were better, etc. And then you also said that there was a big resistance from the providers, because they would feel very comfortable when the baby is there with the nurses and all, and they are really in the control, nobody to really watch on them in a way. But I'm looking at them as a collaborator. So when the parent of the baby, when the mother is there, she obviously has, I mean, the well-being of the baby is closest to her. So these alerts would really be most critical for the woman, because she is going to make a noise that my baby is going to die or something. Please do something about it. And by being there, she is trying to make sure, I mean, she's a support to the nurses there, because she's able to do part of the things that the nurse would be doing. And at the same time, she's also able to create the right alerts, and also able to, in some sense, you know, even this birth companion in the labor rooms that was started has all added improved outcomes, okay? So, I mean, these are the kind of things that I can, when you're talking of, I mean, designs and all that, in governments, you know, you are asked to work, okay, as of yesterday, the things need to be ready, you know. And some of the things like you have public health campaigns, and I asked Gates to, please, we need this, we have to launch this campaign, we need it. So then they went to Ashoka University, got their IT team, and then they said, we'll need this time, we'll this trial and all that, and by the time they said we'll need at least 8 months to put the whole thing. And I said, where do we have the luxury? I need it in a week's time. Now, of course, but this issue around trials, I think it really saves a lot of wastage, okay? So we should, because the resources are constrained, you should look at prototyping and all. So I think it's not because the resource constraint, how do you HCD? HCD, you do it because you are constrained. I mean, it helps because in constrained resources. I'm aware that a lot of times we have failed in governments because we had to launch things in a very quick time. And but just as I was reflecting on design, not really not human-centered design in the sense that you have been talking about, but I'll give you an example of Nilofer Hospital. You know, it's a maternity hospital in Hyderabad, and we were there. And then one of the things, I mean, I'm an engineer, but landed up in WHO, learned health all by experience, okay, having worked in the state governments and the national government for long years in the ministries of health. But one of the things we noticed was that the pregnant woman comes to the facility and then she has to, they take her on a ramp, you know, on a stretcher, on a ramp, and then take her to the labor and all that thing will happen. And then, you know, one of the things that occurred to me, and we asked them that when the lady is going up the ramp, she has the baby in the womb, and that would press against the chest, against the lung, you know, in the baby. Sorry, okay, sorry. So that would be pressing against the lung, and her respiration would be this thing. So why should you be taking her on a higher floor? Let it be on the ground floor. And then the principal secretary health was there, and he said, no, I entirely agree. We will not go on the first floor. We will locate. So it was planned for parking because doctors wanted to just do the parking right on the ground floor. It was decided we'll do the parking elsewhere. We build on the ground floor, and the entry for the pregnant woman would be separate. It will come straight to the triage. But this human-centered design, in terms of trying to look at what will really be good for the patient, that should not be at an incline, but she comes straight and comes to the triage, and then doesn't go to the ticketing counter first, and then she is attended to on priority, and then her needs are addressed. It is all I'm saying is it is so much more critical because it's a matter of life and death, that it is a human-centered design, and one should always be looking at as to who would be most interested in compliance of a particular thing. And then if that person is most empowered, who would be most keen for the compliance, then the chances of the success are obviously going to be much brighter. Thank you.
Thank you. Thank you so much, Dr. Jalani. For someone who knows nothing about HCD, that were many good examples. What we will do is, we have some time left, so we'll do a quick check here with the audience, and based on that, we'll pivot the session. So the question to the audience is, and please participate, is, have you heard enough examples of HCD in practice and would want to go a level deeper? If yes, then please raise your hand. Okay. And let me ask the other question, because it was very leading, bad HCD question. No, we haven't heard enough, and I don't know what these other folks are talking about. I want to just hear more examples and not like go more deeper. I want to hear more examples. Okay. You want to hear more examples as well. Okay, fine. One person, so one person's needs are also important. We will cover examples, but we'll also go deeper largely. So with that, going deeper, one more level is, we talk of this methodology to some degree in an echo chamber, right? Like the community is not here about whom we are talking. It's tough. There is a power dynamic. Language is a challenge, right? Getting someone who speaks Marathi or say some other regional language, making them sit here and then translating. There's just a power equation. We are researchers, right? We are the designers, and we are researching by default on someone. Right, and there is also a lot of parachuting, right? We are not living in those communities. We are going there, whether you spend a day, a week, a month, a year to research and prototype and design and test. We are still external agents. So there's a big movement which has been taking shape of equity within human-centered design. And you might have read articles, human-centered design is dead. Empathy is dead because it's all external stimulus and not from within. And I know we do co-design and sit with them and meet people where they are in their homes. But my question now is, and this is a tough one, and let's start with you, Mr. Mohammed, is how do you make sure that this bias, this power equation is reduced? It can never be eliminated at this stage where we are, but how do you work actively? What is Khushi Baby doing to reduce this, to bring this down and make this truly, truly closer to what equity would mean in such a process?
Very deep question. As being the ops lead, I always take tough questions. Okay, so, right, so I mean, in order to answer that or to explain that, you don't need to go too deeper. See, I'm telling you, we work very closely with the government. So Dr. Jalani is here. And for the government, the timeline is always yesterday. when we talk to, we work with secretaries, we work with mission directors, the turnaround should be fast. I give you one example again. So last year, so for Khushi Baby, we provide digital solutions primarily for the frontline workers, and that is our bottom-up approach. And where we are deeper into the community and community engagement with them. But when the phase came, the different phases, we rolled this out, and there was a phase when we realized that because of this number of applications and because of number of digital interventions at different level, now we have battling with the challenge of multiple applications also. That's where this platform concepts came and all the good work that we do claim, but I still see the impact yet to come. And the impact in terms of program outcome, that is the real impact, what we see actually. But who is the decision maker? Primary decision maker. And in our process, or this process, the primary decision maker, what we see is the government officials, sitting at the district level, block level, or the state level itself. So last year when we were attending a meeting at the state level, and we were supposed to talk about the interoperable or integration with some national portal. And this was one of the agenda, supposed to be one of the agenda of the government conversation. And so for some reason it was not discussed at that time by secretary. And this again, the second thing come, and that is about, she wants to talk about the aspirational block indicators. And for those who don't know aspirational block, there's a high focus blocks of the India where the development indicators is a concern and government wants to improve that. And she wants to discuss this, where is the portal, where is the dashboard, where I can see all these indicators from different maternal health, child health, the education indicators, the access to drinking water. So all this comes together and gives you the holistic approach. And this is a very basic thing, and we don't have a unified portal for that. Then we suddenly realized, is it always correct to go bottom up, or is it time also to think about the going top down in this way, where we should empathize with these government officials. And when we talk to them, we see that they have to battle with the 10 different portals, the dashboards. And there the idea of AI-enabled integrated dashboard come to our team, come to mind of our team, and then we develop this. And there on the same portal, we didn't develop anything new actually. We just integrated the all dashboard at one place. In fact, some of our team members doing things manually at the back-end level without API functional even at this stage. So that we make their job easier, and they really adopt and they really look into the indicators which are the top concern for them actually. And we launched this, and earlier this month, Honorable Chief Minister launched that dashboard, and we're looking forward to integrate the other human-centered approach with our AI-enabled Samvadini, where we can talk and chatbot kind of thing with the dashboard officials can. So right, I mean, the point is that equity for me is to empathize not just for the grassroots, but also at the top level where they are sitting actually. And we understand that they know everything, but with simple solutions, with simple approach, with simple turnaround, we can help that level also. That's all I have to say.
This is great. I really want to appreciate you for bringing in, like, when we talk about human-centered design, it's not just community, it's also the government administrators, the health administrators, frontline workers, and other folks, because they are also doing tough jobs end of day. An example comes to mind to satisfy. One person had said a few more examples is, we were working to roll out tele-health e-Sanjeevani portal in Uttar Pradesh with our friends at Japaigo. And we were doing some HCD-based research to say, how can we make this smooth, people adopt and use it. And while there are a lot of patient-centric things I won't get into, there was one very interesting thing we learned about the chief health officer who actually runs the health and wellness center. They were feeling threatened, a lot of them, and for right reasons, because they are locally known as Chota Doctor. They are not doctors, but they are the ones who are the first point of contact for the patient, are trusted, and just like our pharmacists give out medicines, they do a lot of consultations. So how do we bring in a digital system while maintaining the equity and trying to solve for the respect and trust that the CHO has became a very important thing. Once we knew this, it wasn't difficult to solve for because they could be included in the process flow and not be bypassed. Actually, they could become a great ally to collect a bunch of things. So with this example, but I would also turn to you, Sri Rupa, and ask you, how have you encountered this? You gave a number of 100 million, if I'm right, for Swasti. Yeah, so you guys are moving fast. That's a big number. And
that's where we want to get to.
So you guys must be
By
moving very
2030.
fast, right? 2030, not many years left.
By 2030,
So
yes.
do you get time to think about these things? Because, you know, sometimes equity, power, bias, these sound like terms that, hey, I had a lot of money, I was sipping coffee and thinking about this. So in our resource-constrained development settings, you need to reach 100 million. How do you find time to think about this if you do, and if you could give an example?
So I'm going to answer this in different layers, all right? Let's just have a very layered bit of a conversation. One thing that, see, Swasti would not exist if our communities did not need us. Let's just be very, very frank about it. We are not here because we need to do this. And our work was born out of when India was trying to ensure that an HIV epidemic does not happen, right? Many of my colleagues from the HIV days are here actually in this room, and I thank you for being here because at that point of time, I was not in Swasti. I was in National AIDS Control Organization. And for me, the moving happened because we realized that when I say we here now, I mean development sector practitioners, is that there is a gap when it comes to what you're talking about, you know. Equity, bias, all of that are not just dictionary words that we like to throw around in AC rooms. It is very, very real. It's very real, and it is something that our communities, when I say our communities, all communities in India, all vulnerable, marginalized communities in India are fighting for, right? And you can look at it as an activist, or you can look at it as someone who is a facilitator in different spaces, right? But you cannot not look at it. And one of the first questions that you have to ask yourself, and this is not prescriptive, but this is something that I would suggest, is not about are we including everyone, or rather the question should be, are you excluding someone? And then design for that. Because the moment you say, am I including for everyone, your first answer will be yes, right? What Dr. Jalani said was so powerful. What he said about the woman going up on the ramp, right, while pregnant with a child and then probably having acid reflux. And we've all had acid reflux at some point. That's Indian food. But no shade. But that is the reality, right? Because you have never thought about it from that way. Who am I excluding? But I've designed the ramp. If you say, am I including a pregnant woman who needs a wheelchair? Tick mark, yes. Yeah? To come back to what you were actually asking in terms of, do you have the time? One thing that we have to always ask ourselves is, when we say resource, what do we mean? We often say the word resource constraint settings. There are constraints, yes. Money is a constraint, let's be very frank. Yeah? It is also abundant in different places, which needs to be unlocked. Time, if you look at one human being's time, that's a constraint. But when you have an entire community fighting for something, and you're trying to solve for that, that's that entire room. As consultants, sometimes we say that this team is 100+ hours experienced. That's not one human being. So how do you look at resource? And when you say resource constraint, that matters. So yeah. two layers in this conversation. Back to you.
Thank you so much. Quite thought-provoking. And 100 plus hours with nowadays conversations could be one person, right? Yeah. So not getting into the politics of that, but let's get into the politics of HCD with that. And Samina, this question will come to you, as you would have imagined. While equity is an important aspect, right? Power, bias is, so is historical marginalization, right? And we deal a lot with that in healthcare settings, right? And I'm talking about navigating the politics, not the governmental politics, but the politics of health systems. And HCD is political. This is something I didn't learn in school, but moment I got out, in 2 years I knew that human-centered design is political, because who the human, which was raised here many times, makes it political. Because society operates in a certain way, and we need to navigate that. There is religious marginalization, there is caste marginalization, there are many types. There is gender marginalization, there's rural versus urban marginalization, and you can put more and more layers to this. So, Samina, given the work Noura does, can you give us an example of like, how does HCD intersect, like how do we bring about this nuance of the politics of health systems within our HCD process?
That's a very loaded question. And I mean, I don't know exactly how to go about answering it, because it's a very, very real thing that happens the moment we step out of these AC rooms and we actually hit the ground. The politics of the situation, the power dynamics, the way decisions get made, it impacts everything so deeply that all of our solutions, all of our assumptions, all of the things that we want to do and the change that we want to make, it sort of falls flat. I think it starts with intent for us. I mean, when you are designing, when you're practicing HCD, it starts with having the right intent of what is it that you want to do. Honestly, being in touch with that intent, and to add to Shree's point, that it's about understanding not just who we are including, but who is it that we are excluding. For us, the way it shows up is just very thoughtful exercises on understanding that ecosystem and acknowledging it. It's okay if we are not able to change that ecosystem, but it is extremely important to acknowledge it. It's extremely important for us to say that in this context, for example, here we are going to a district hospital and giving material or information or giving these programs on nutrition, but most of the population that's coming in are from tribal areas. They don't have access. Or we are talking about these digital solutions all the time, like WhatsApp or app and this and that, and what does that look like once you move to the real world settings? How many families have phones? If there are phones, what is the gendered usage of that phone? Like how many, we are targeting our messaging to mothers. Yes, so like a new mother needs to know this information. What access does the mother have to that phone? Is she even able to interact? Is she even able to look at any of the material or any of these brilliant solutions that we're sitting and designing? Sometimes we design for the middle of the bell curve. We have to. When we are looking at scale, we have to design for the majority. But we need to absolutely like deeply acknowledge, write down in front of us in big bold letters, who are we excluding? We need to know that these are the people that are getting left out, they are getting missed out, so that whatever next iteration, whatever next version of this, we can be thoughtful about them in some way. Take one step towards them.
Thank you so much for talking about the politics of exclusion in health systems and where HCD intersects. While at Dalbak Design also we've been doing a lot of work to push this methodology. We do falter, I think, and it's been hard to accept that it's okay to make mistakes, but keep pushing this. Once I was talking to the founder of Koro, Sujata, like brilliant organization working for grassroots gender movement. And I ended up using the term democratizing mental health with her. And we had a planned meeting, but the next 2 hours just went in unpacking. She's like, what do you mean by democratizing? And democratizing for who? And it was a great reality check for me and in that way. But I know, Mr. Mohammed, you want to give one quick example. After that, we'll have a short question for Dr. Jalani, and then we can open it up for audience questions. Okay, maybe that could be to help bring. But I have a little spice addition for you after that. Yeah.
All right, I'll give you one example of this democratization or the politics we are talking about. How this design or digital solutions is basically empowering the last mile workers. I can give one example. See, I mean, in rural India, there's a reality that we have a caste-based mohallas, right? So this so ASHA worker belonging to different caste cannot go to the mohalla belonging to different caste. So see, this is a situation, reality we are living with actually. So we are giving the tablets to the ASHA worker for nurses for the immunization, and these ASHA workers are not supposed to go to the community of particular caste. So and that particular device has one feature of biometric authentication, whether that child has received a vaccination or not. We are using some fancy technology way back 7-8 years back. And what Asha did actually, she then asked them, you have to come to my center to get this biometrically authenticated. So I cannot go to your place, but you have to come to my center to get this done. And that's how, this is one example, but this is how technology can change the equation also. And this is one example I'd like to mention here. It's an old example, but just came to my mind, so that I should share with you.
So first of all, thanks a lot. And okay, that's a 10-minute reminder. We still have some time for questions. Dr. Jalani, while you give an example, please also, as we open it up for questions from audience, could you give us something hopeful as well on this, right? We all have been like going quite some on the doomsday, exclusion, these challenges. So while we want to hear a hard example, real example, but also being the World Health Organization and authority on public health, give us a hopeful ending. Yeah.
Thanks. I did mention that these people-centeredness, equity, are very key things as far as WHO is concerned, and these are, drive our programs. And even when we are trying to reach out to, say, immunization coverage, who are the ones who are really being left behind? And then when you're looking at it, these are those marginalized populations. But I'll just first give you a good example in the sense of how to try to drive equity. Of course, one mechanism, of course, is through the very disaggregated health information systems. And just give an example. So I recall way back in around 2003-04, and a chief minister was holding a meeting, and this was not on health but on education, and all the secretaries were there. And then Sarv Shiksha Abhiyan and the Secretary of Education made a presentation that we are doing very well. We have got 100% enrollment and all that, So you have the numbers. So there's an estimation of number of children within the age groups of 6 to 11 years, okay? So suppose this is, I'll say this is, say, 10 million, 1 crore children ought to be there. And then you have number of children enrolled in schools is 1 crore, 1 lakh or something, or whatever. So then the enrollment rate is then 100%, okay? And obviously what happens is that it's not only 6 to 11-year-old, there will be 12-year-old, 13-year-old, etc., who are also enrolled in the school, and then it gives a feeling that almost everyone is included. So there's kind of about inclusion. And then the CM, then she asked me, Manoj, what do you have to say? And then I said, ma'am, my understanding is that we have a certain percentage of disability, okay, so it's about 3%. We have a certain percentage of scheduled tribe population, 21% in our state. And then we have girl children, which is almost, say, 950 or something, 2,000, etc. So now, if we were to look at tribal girl children with disability who are enrolled in schools, let's try to get the number. If it is anywhere close to what we are expecting it to be, we can assume that we got every children on the board because it has all the intersectionality, tribal, girl, disability, etc. And the room went quiet. Okay, so of course then they said we do not necessarily we have disaggregated information on tribals and girls and all. I said this could be worked out, but if we are really trying to reach out to one who is most likely to be excluded, then this is how we need to design our systems, which would then be equitable. So in terms of how you align your incentives for services, okay, how many of the scheduled caste and scheduled tribe children are really being enrolled and being provided the services, and not based on that and the services rendered to, you are providing enhanced incentives. So there could be ways in terms of how do you incorporate equity in the design based on the reality, based on the context, and try to make sure that we are able to ensure that health outcomes for all population groups are good, and there are good examples on that. Thank you.
Thank you so much. And I think as we open up, I just have like one final closing statement would like to hear from everyone. And if you can keep it very crisp and brief, and what would you like people to take away? I think for me, it's been, I know before the panel I had said like 15 people attending would be a success. So I'm very happy there's much more than 15 and interested people who are listening intently about this topic. And hopefully through the practical examples, successes, failures, and where the today the field is, take away a little bit more knowledge about this and are able to push this agenda in your own firm. So that's my takeaway. But if we can just go in a queue one by one, very brief, crisp, and then we can take multiple questions.
Sure. So for me, as I said very early, that SED is something which is experience for the user of this application, digital applications, experience for the beneficiaries, the village people, the urban people, and because we are working in a space of the technology and working to filling the information gap. So no one should die because of lack of information. That and there this experience would come as the prime focus as a group we are working. So that's all I have to say. Thank you.
People-centeredness and equity, core values, compassion, the highest virtue.
I would go to, I think one of you had used this, that you don't worry about HCD because you're in resource constraints. You use HCD because you are in resource constraints. So I would definitely want that to be a motto people take away.
I think all of you know what I'm going to say. Who are you excluding? Always, always ask. The second is that always remember you yourself are a human being and the people you're designing for are human beings. And never forget that, and always ask yourself, who is the human that I'm designing for? Yeah? Back to you.
So thank you so much. If you can have a round of hand for our panelists today. Yeah. And thank you for patiently listening. So we'll take a few questions. My request would be if you could share your name, where you work, and directly jump to the question. We'll just hear 3 questions first, then we'll get some responses. If we have time, we can take more. Like here, someone in the front, you had a question, so let's start with you. And then that person at the back who had the hand raised, yeah, ma'am, your hand raised very much. And let's have someone here, and then we can go for more. Yeah.
I'm Sama Mahalati from the Foundation of People-Centric Health Systems. It's a Delhi-based foundation. So I had a thought while thinking about this. Like, you know, one thing is that we design our interventions involving the people, but what about when we reflect and evaluate our interventions? Are those people involved in that process? maybe if we involve them, that is when these things like exclusions, inequality, it may come up when we involve them in that process at the grassroots level. So I don't know what your thoughts are. So I was thinking like, you know, designing, action, reflection, and then action again, and reflection with the people for whom these interventions are designed for. So I would love to hear your thoughts on that.
Okay, thank you. And I've noted the questions to you, and then someone there back, ma'am, do you have a mic?
I don't have a mic. Hi, I'm Malika and I work for an organization called KHPT. My thought and my question to the panel as a whole maybe is, human centricity as an approach or as a thought, I think we were practicing it way beyond human centricity, became a discourse or a model. So what in our experience, what we found is the frameworks and the tools of a discourse is boxed and has been limiting. When you want to emphasize on the fluidity that is required when you work with people, how does one overcome that? The second thing is, how does one decide whom to center and whom to decenter, and what makes us think that we have the power to center or decenter in a process like this is also something that we've been thinking about a lot, because we've had communities throw our posters into the bin and tell us it doesn't work. So are we allowing that kind of audacity, and do we give that much power and autonomy to the people that we engage with? And that, I think, is really being people-centric. Thanks.
Thank you so much. Really good question. And
hi, thank you so much for this session. I'll jump directly to the main question I wanted to ask, which is the HCD concepts are really beneficial. They are like, we can feel the difference when we use them. But working with state government, so I'm working with CGIS Foundation, which works on governance issues in states. And the two biggest constraints we see is, one, how do we create resources for doing HCD? Like, as sir was saying, everything was required yesterday. So most of the states are working with IT vendors who don't even have a designer or even UI designers in their team. So how do you even bring some space for this kind of work, prototyping? Second is, there's a lot of influence of government of India on states. Often it's dictated by union government to the states how the app should be, what should be done. The states don't have any voice in the design of those apps and platforms. So Khushi Baby is doing a lot of good work there, but just wanted to hear any tips on this.
okay, thank you. So, so if we just give, like, let's just quickly answer these, and then if they give us a little more time. So the first, yeah, and of course, people are available post this. Let's start with the first one, the action reflection point that you had here, and how can we involve people better, especially in the reflection part, so that the action becomes more refined. I'm just paraphrasing.
I'll take
to
that one.
Yeah.
There's this beautiful methodology. It's relatively new. It's called empowerment evaluation. Okay? I'll find a way to connect you to the person who has created the methodology. Okay? And that completely answers your question. In the interest of time, I'll let you move on.
And another, the old school MEL, measurement, evaluation, learning, more and more I've been seeing acceptance to have HCD-centric processes to develop your MEL log frame, because we do that often. So of course, a bunch of it is quantitative data that needs to be checkboxed and simple outputs that we need to measure. But there is more and more openness to make our data collection for evaluation a bit more human-centric. Coro is actually doing wonderful work around that. Happy to connect with Sujata again. I know the KHPT question, which had a great comment, I think it had two parts. Maybe, Samina, you want to take one at least. One was around the discourse. It's a little boxed, the settings we work with, people we work with, how to bring fluidity. And I think the second one was a very pertinent one, that who gets to decide who's included, excluded, going back to the politics that we talked about. So if you want to throw some perspective on that.
I'll probably attempt to answer the first one, and I'll give it to you for the second. And the first one also ties to the last question that we had around how do we put resources around this. Is one of the things for us to do is this, to not box it as design. The thing that happens is human-centered design, because it has the word design, is associated with designers. It's not supposed to be. You are not supposed to have only designers doing HCD. That sort of defeats the point of it. So we have to figure out ways of working, and that sort of becomes very particular to the organizations, to the setups of how do we break those molds. A lot of the onus is on designers also on this, because, and I don't know how many of the people here in the room are from that background, but a lot of the onus is on the designers to not hold it as something that's just theirs. There are methodologies, there are frameworks that exist for the greater good, so to speak. And like you rightly said, human centricity has existed. One of the common things that happens is when I talk about human-centered design in my organization also, or in anywhere else, the first response we get is, but that's common sense, right? Like, don't we do it already? Yes, we do. And what we just need to take from HCD is the discipline, the frameworks, the way to communicate back, some methodologies, but we have to actively make the effort to not box it as just something that few people can do, and it has to be something that everyone follows with an honest intent.
Thank you.
Part 2.
Yeah, if you want to
yes.
throw some light, please.
Malika, thank you. Malika has traditionally always pushed us to think better, think more out of the box. So I'm going to try and answer your question on who gets to decide, and especially your question on what gets centered, what gets decentered. One thing that I have learned is that centering someone does not always mean decentering someone else. And in communities, if you are integrated into the community, either directly or because of who we like to call in the sectors community health workers and frontline workers, what really helps is to make it issue-based. So what is this issue? Who does it affect the most? And the community themselves then be like, oh, if this affects these people the most, we will step back. And suddenly concentric circles of power gets formed, which is beautiful to watch, where at the center of the circle are the people who get most affected. And right outside you have supporters. You will still have naysayers, but you know who really tackles the naysayers? Those concentric circles. Wow, my time is up.
Okay.
Over to you.
I know there was this last about state and all, maybe a 30-second response, and then we close it.
Just briefly, I can discuss this with you later. Your question is more to do with the system-centered design, actually. I mean, we have been working as a non-profit tech startup and working closely with the government. So we ask government, we are not going to support you in program at this moment, and you don't have to go for the tendering to hire an IT vendor to develop all these solutions. We as a non-profit tech startup will support you in designing, developing, and deployment of all these solutions. So that's how we navigated between this government thing, and that's why we accelerated the process of developments. I can tell you the more stories, we can meet offline. Yeah, thank you.
We need more cushy babies, basically, to solve for what he's saying. I know there have been lots of beeps that have happened, so we will sadly need to close this session, but folks are around for discussion, so please stay back. And again, really, really appreciate, we should have a round of applause for you guys. Sticking around the last session. It's been 100 sessions plus. It's been hectic. This is the 110. It's hectic. It's 2 more. It's hectic, and it's quite something. So thank you everyone. Thank you so much. Yeah.